My name is Ken Ferraro, and I'm director of the Center on Aging in the Life course. And it's my pleasure to welcome you to our symposium on aging, families, and health. We're going to focus today on social influences on health lifestyle choices in later life. I believe you're in store for a great afternoon. In our society, with its emphasis on evidence-based medicine, health and healthcare are becoming very complex. We get dozens of messages each day about health issues. And that's a good thing, but the problem is that some of those health stories conflict. Is coffee good for you or bad? And if it is good, is there too much of a good thing? And healthcare is very complex. Health plans for many Americans change every year. So we learn what our health insurance covers, and poof, the next year it's different. You could argue that healthcare in the United States is a fabulous system, but you could also argue that it's not really a system. It's just disjointed and it's hard to figure out. And so, not surprisingly, what will the Affordable Care Act offer to persons in those health exchanges? Navigators. Yes, it's coming. GPS for healthcare. Well, many of us have found that when we're trying to negotiate decisions about health, protecting our health, or seeking health care, that we want some help in navigating. But I don't know about you, but if I'm in a whitewater raft and I'm headed down the rapids, I don't really want to push some buttons on my phone to get a call center for help on how to get down the rapids. So what do? I oftentimes turn to family or close friends, and I trust those people for some expertise or some guidance on how it is that I should handle the things in front of me. So today we're going to focus on this question of how families help us navigate the healthcare choices in later life. And even if our family members aren't asking, how could we offer stealth advice to help them make good, informed decisions? These are the types of questions we're going to address today. We've assembled 3 of the world's most prominent scholars on the topic to help us answer these questions, and I'm very glad that you decided to join us. Welcome. For those of you who pre-registered, you should have received a booklet with some information to help you navigate today and follow up on these issues. There's bios on our speakers, as well as some references for further reading and note cards. We'll conclude the day with an award presentation, a poster session, and a reception, so I welcome you for the entire afternoon. 3 organizations collaborated in making today possible. So the Center on Aging in the Life course and the Center for Families worked hand in hand to plan and organize this event. And you can see 2 of those logos up here, and they're on your booklet. It was back in 2001 that CALC launched its annual symposium series. And over the years, we've attracted some retirees from Purdue to these symposia. This year, the Purdue University Retirees Association, or PURA, as many people refer to it, took it a step further and offered to co-sponsor our symposium. I'd like to invite Bob Bain, president of PURA, to offer a few words of introduction. Bob?
Well, thank you. PURA, on behalf of our 4,000 members, official retirees of the university, are very proud to be helping to make this symposium possible. This is kind of an experiment for us. It's the first time we have done so under the blanket of our Opportunities and Activities Endowment. And I see a number of retirees out there in the audience, so I think this is something that struck home. Pura is a great way that retirees can stay connected and stay active both mentally and physically and socially. So this really fits into our mission and purpose and the kind of things that we do. And we're hoping that this will be of great value to all of us. Thank you.
Thank you, Bob. And with the support of Pura, we are actually video recording the proceedings today. And it is our intent that we can make that available to people who are unable to attend today, as well as for instructional purposes. Thank you, Bob. Now, to help kick off our afternoon, I've invited Lindsay Wilkinson to introduce our first speaker. Lindsay is a doctoral candidate, not just a doctoral student. She's a candidate in sociology and gerontology, the dual title PhD program. Lindsay?
Thank you. This afternoon, I have the pleasure of introducing Dr. Deborah Carr. Dr. Carr is a professor in the Department of Sociology and Institute for Health, Healthcare Policy, and Aging Research at Rutgers University. Dr. Carr is also co-director of the National Institute of Mental Health postdoctoral training program at Rutgers Institute for Health, Healthcare Policy, and Aging Research. Her research has been supported by the National Institutes of Health and focuses on work and family experiences over the life course, bereavement and end-of-life decision-making, and the social and psychological consequences of body weight and obesity. Dr. Carr has authored or co-authored more than 75 articles and book chapters, and her work has recently appeared in the Journal of Health and Social Behavior, Journal of Gerontology, Social Science and Medicine, and The Gerontologist. Dr. Carr currently serves as deputy editor of Social Psychology Quarterly and Journal of Marriage and Family. And she is putting the finishing touches on a book for Rutgers Press titled Worried Sick: Why Stress Hurts Us and What to Do About It. Dr. Carr is also co-investigator of the midlife development in the United States and the Wisconsin Longitudinal Study. In addition to all of this, Dr. Carr plays classical flute and piano. She enjoys running and has recently taken an interest in hiking. This summer, she climbed part of the Alps and the White Mountains in New Hampshire. She is a remarkable scholar and a wonderful human being, and we are honored to have her here with us today. Please join me in welcoming Dr. Deborah Carr.
Well, first of all, thank you so much for that warm introduction, Lindsay, and Kat, and to everybody who's been such a gracious host on this visit so far, including my ride that picked me up to the airport yesterday at about 1:45 in the morning, so thank you. And I don't see her here. Maybe she's still napping, but we'll talk later. And let's see. I need to find my slides here. Laptop? Escape. Thank you. That's always the hardest part of the presentation. But again, thank you so much for your warm hospitality, both to Purdue and to Indiana. The only part of Indiana I've been to before today is that little part way up north between Madison, Wisconsin and Ann Arbor, Michigan. And it's very beautiful down here. So I really have enjoyed my time here so far. And what I'll be talking about today is a topic that is very relevant to the theme of the conference. And part of what I'm talking about is something that lots of us in the room know about already. How is it that personal relationships and the status of our relationships affect health and behaviors? That's something I know a lot of scholars in this room have expertise in. But what I'll be doing that's a little bit different is focusing on a set of outcomes that at least the young people in this room probably haven't thought about very much, but the older folks might have perhaps. And it's how it is that we prepare for the end of life. Not an uplifting topic, but an important topic that we all need to think about, and a topic that truly is sociological. And you'll see why that is as I go through the talk. And so I'll be talking about how and why family relationships affect end-of-life healthcare preparations. And despite these lofty claims by poets and scholars to say we're born alone, we live alone, we die alone, no one actually dies alone. Most people die surrounded by loved ones. Most people, when they think about how they want to die, incorporate family members into that. And not to ask too morose of a question, but just think about how you would ideally like to die. Okay, most people say they'd like to die peacefully in their sleep, in their home. Or if it has to be in a hospital where about 75% of people will actually die, it's surrounded by loved ones and family members. So again, this notion that we die alone has perhaps support by the sad, morose, poetic community, but certainly not by the research community or the medical community. And specifically, the type of care we receive at the end of life, which often requires very intense decision-making, and I'll say more about that later, is something that tends not to happen in isolation. We make these decisions with our family members, or at least we should, because the family members will be the ones living with the ramifications of how it is that one chooses to live or die. And so just colloquially, people talk about, if I'm ever a vegetable, pull the plug. But if you're the family member who has to be the one that says, yes, it's time to take mom or dad off life support, certainly you can imagine that they might have ripple effects, not only for one's adjustment as they deal with the death, but how they deal with their family members. So death, again, is not a solitary experience, nor is the dying process, which is actually just as important as the actual death. And so patient-centered care is something we hear about a lot when Ken was talking about healthcare earlier. But patient-centered care encompasses care that, according to the Institute of Medicine here, is care that informs and involves patient and medical decision-making and self-management. So when we hear a lot in the medical community about patient-centered care today, the subtext is that it's an individual making these choices, that we as individuals need to be well-informed, and we need to articulate and be autonomous about what kind of healthcare we want or don't want at the end of life. But I argue, again, this is a fairly limited view, and when we talk about patient-centered care, perhaps we should talk more realistically about family-based care, of which the patient is just one part of that equation. So again, I just want to move us away from this notion of death as solitary and really bring it into the family, and especially family scholarship. So to get back to kind of nuts and bolts, I'll first start out with my aims, and we'll talk about why this topic is something that I think is important. Hopefully I can convince you of why it's important, what some theories say about why and how family members will participate in end-of-life decision-making and end-of-life preparations. And then I'll walk you quickly through results from a couple of studies from a bunch of data sets, and then introduce you to a new data set that I'm collecting that I think will actually be a really nice set of materials for lots of us interested in family-level decision-making and family dynamics. So just a couple of the aims. First and foremost, I'm going to investigate whether and how the legal status, trajectory, and quality of one's romantic partnership affects advanced care planning. Again, that sounds all very, dry, but the motivation for one of the questions I'll look at today is this observation that we found in the family and health literature. Right? We know that being married is good for our health. On average, married people live longer, they're happier, they're healthier, etc. Of course, it depends a little bit on the quality of the marriage, but marriage protects us. But there's an interesting wrinkle. There's been a variety of studies that show that it's not all marriages that are protective. It's legal marriage. Marriage tends to give us more benefits than non-legal marriage or cohabitation. So why is that? Likewise, first marriages tend to confer more health benefits than higher order marriages. And my question is, okay, given that the marriage is considered the one form that protects our health and keeps us behaving in healthy ways, does that extend to this outcome of advanced care planning, or how we prepare for end of life? And one of the arguments I'm going to make is that end of life planning is a health behavior exactly as smoking or drinking is a health behavior. We don't smoke or drink now, at least some of us don't smoke or drink now, because we know it'll compromise our quality of life down the road. But likewise, end-of-life planning, meaning telling doctors what kind of medical treatment you want at the end of life, or what kind of life-extending treatments you do not want at the end of life. Making preparations for that now is a health behavior that might actually spare you duress and intrusive and futile care at the end of life, and likewise duress for family members. So again, that's some of the literature I'm drawing on, this notion that our family relationships now might help us to engage in protective health behaviors, even if we don't see the fruits or returns of those health behaviors for quite some time. So that first study here of how it is that the legal notions of aspects of our relationship and the quality of our relationships affect advanced care planning is something I'll study using data from the knowledge networks. Then we'll talk a little bit more about what happens in the relationship and study the ways that relationship dynamics, meaning whether it's a close-knit relationship or a conflictual relationship, how those type of relationships affect not only whether you prepare for the end of life, but with whom. Who do you engage in the process? And I'll use 2 data sets here, New Jersey End of Life, which is one of my surveys, and Wisconsin Longitudinal Study. And you know, this question kind of seems like a no-brainer. We might think, of course you plan with the family members you're closest with. But as you walk through the talk today, you'll see there are a couple of tensions. You know, if you want a living will or a document that tells people what kind of end-of-life care you want at the end of life, on one hand, it's sensible that you would go to those family members you're closest with and that you can talk to. But let's say you have one son or one daughter who you just don't get along with, and you know that your end-of-life care is going to fall in their hands. You might feel all the more compelled to put your preferences in writing to kind of wrest the decision-making process from that family member who maybe didn't always have your back in life. So again, there really is an interesting puzzle here. Is it that we do a certain behavior in order to help our family members and draw on their strength? Or likewise, do we engage in end-of-life planning, meaning writing a living will as a way to forestall the possible outcome that a family member who doesn't have our best interests in mind might make a decision that doesn't particularly benefit the dying patient. So there is some dramatic tension here that it really could go either way. You'll soon see the answer. And then if there's time at the end of the talk, I'll tell you about a new data set I'm collecting now called the Wistful, because we always need cute little names for our data sets. But this is a study called the Wisconsin Studies of Families and Loss, which is a study of recently deceased older adults. But more importantly, it's interviews 2 of their next of kin, a spouse and a child or 2 siblings, and really hearing from those multiple next of kin what happened when this person died. What were the sources of family conflict? Did they receive the care they want? If they didn't, what are some of the sources of that? And so it's a data collection that's in the field now, but it's just coming out of the field, and so I'll be able to present a couple papers on this at the gerontology meetings in November. And again, it'll be available to the research community for those who are so inclined to analyze these data. So that's the big picture of what I'm doing. Just to give you a bit more motivation, for those of you who are new to the topic of advanced care planning or end-of-life decision-making. Advanced care planning is the big label we put on a couple of specific behaviors, such as writing a living will. But we engage in end-of-life planning, meaning putting down on paper the medical treatments we want or don't want at the end of life, and likewise appointing a family member to be our advocate, to be our spokesperson, to tell healthcare providers what kind of care we want at the end of life if we ourselves have cognitive impairment and are unable to communicate that decision for oneself. But why do we do this? Okay, the rhetoric is that we do this because it helps us to ensure a good death. If we call the shots, if we say, no, I don't want a feeding tube, then you presumably will get the kinds of treatments that are consistent with your desires. And I would argue, if you plan at a family level, with the desires of your whole family member, with your whole family unit. And I suspect some of you in this room, unfortunately, have witnessed the death of loved ones that were not good deaths at all. Right? You've seen someone hooked up to wires. You see someone dying in a way that you find not comfortable for them in any way. And end-of-life planning is intended to forestall those type of problematic deaths. It's also intended to forestall or to just get rid of family-level conflicts. If there's no end-of-life planning and let's say one sister decides that we should pull the plug on mom and all the other siblings say, no, don't do that, clearly you can't both have your ways, and think about what that might mean for family relationships after the death. This could be a source of real conflict. And so all of those reasons leads us to believe that yes, we should put our preferences on paper because it will lead to better outcomes for the family members and for the dying patient. Okay, so that's us as kind of advocate speaking. But as a researcher, we often know that you can't ascertain causality that easily. Is it really the advanced care planning that helps people to die better? Or is it the kind of people who do advanced care planning or educated, smart people who get along with their family members in the first place and their death would be as good as a death can be even in the absence of the planning? It's really important to parse out what is the lever leading to this outcome if we do want to invest our time and energy into public policies that enhance these type of behaviors. So that's a kind of secondary aim of what I'm talking about today. If I find out it's only happy families who are doing end-of-life planning and then they're kind of happy as one can be after their family member died, is it really that it was the legal documents that helped? Or was it these people would have had actually a fairly fine outcome, again, given as fine as one can be after a loved one dies, in absence of those documents? So again, we always have kind of a policy and practice agenda, but then a scientific agenda of trying to figure out exactly what is the causal mechanism here. Again, advanced care planning, I think, is considered a core aspect of the patient-centered care that we heard about earlier, but I think the emphasis that we've had on the individual level really conceals just the importance of family in this process. Again, just as family is important in helping with all forms of health behavior. So that's the motivation behind the talk today. And so just to give you a little bit of background about why we care about this topic and how can you plan for death? Some people will say death happens. You know, my grandmother used to say you can die slipping on a banana peel, so why plan? I think something got lost in translation from Polish there. But we all know that, you know, you could die an anvil drops on my head. But no, I mean, we think about those things. And when I ask people to tell me what is the ideal death, most people, a lot of men say, I just want to drop dead on the golf course, you know, in West Palm. You're not going to die that way. Very few of us are going to drop dead on the golf course or at a great sale at Loman's. I mean, whatever is your ideal way to die. We're not going to die that way for the most part. And why is that? It's how we die. And it's not actually the event of death that is important. It's the process of dying, which is getting longer and longer today than it was in the past. So again, just to think about gloomy topics for a moment, there are about 2.5 million deaths in the United States each year, and almost 3/4 of them happen to people over age 65 and older. So again, as much as we see televised deaths of young people on television, it's truly devastating. That's not the statistical norm. Age is one of the biggest predictors of mortality. But we think about not only when people die, but how they die. The 3 leading causes of death today are heart disease, cancer, and upper respiratory disease. Again, these are diseases that unfold and unfurl slowly. There's a very long and increasingly long duration between the time you're diagnosed with the condition and the time that you ultimately die. And that's a period that some scholars have referred to as the living dying interval. And so it's filled with both good and bad things is one way to think about it. At some level, it is filled with long and prolonged suffering in some cases, but also it's a time period that the family can prepare for the future and use that time to think about medical decision-making, financial planning, as some of you are interested in. And so it's really something that's an interesting period to study. Again, and we know that that living dying period is long and prolonged because with medical technology today, people kind of know that they're dying and that period of dying is prolonged because we can sustain the lifespan, even if it's not necessarily a healthy lifespan. But also that living dying interval is not always filled with times of being mentally aware and able to make decisions. We know that specifically at the very end of life, there's physical health decline, psychological distress, and very importantly, cognitive symptoms. And all of this means that the individual dying patient might not be the one who's able to advocate for him or herself on the deathbed, and the family members really have to be the ones to intervene and talk about whether treatment will be accepted or rejected or requested or ignored. And also during that time period, these decisions, they're difficult and there's no right answer. Whether we want treatment or not, there's no right or wrong answer. It's based on a variety of things that I've written about in other papers. Some has to do with religious or spiritual views. We know there are race and ethnic differences, our faith in the medical system, our reliance on faith versus science. There are a whole collection of factors that determine whether someone wants to, again, be strung along or to have the plug pulled, call it colloquially. No right or wrong answers. But the important thing is that people get what they want. And if they do not put it down on paper or have an advocate, there are higher chances that one will not get what they want. And that's part of the reason why, again, the family is so important. There's some evidence that suggests that the default treatment, if you do not say, hey, stop treatment, you will receive any treatment available because that's what doctors are trained to do. But also there's some evidence, and sketchy evidence, that people who can't afford to pay, especially blacks and Latinos, sometimes may not get the treatment they want. We know that blacks and Latinos on average want more life-extending treatment, but sometimes due to things like compromised ability to pay, they might not get it. So these errors can happen on one of two ways: getting what you don't want or not getting what you do want. So again, all the more motivation for doing this kind of planning. Again, this is just a little picture here to think about, but why should people plan? Sometimes people think they're going to make plans and put down on paper what kind of treatment they want when they're really sick, really at the end of life. I don't need to think about it now. I'm 40 years old. I'm going to live forever. But as any of you know who has watched a family member die, Death is not really predictable, right? We all have seen a family member that has a chronic illness and they really crash. I'm like, oh my God, they're going to die today. Then they bounce back, and our hopes are kind of raised. We're like, oh no, look, they recovered once. We don't need to do advanced care planning. But then what happens? They go up and down, up and down. And so there is this unpredictable element. So the fact that this kind of is a portrait of what kind of death looks like, this unpredictability, again, is all the more reason why people need to do this planning. And planning done too late is not really efficient. You can't do, and you have someone write a living will once they're already on a very severe decline. So again, this is all by way of saying end-of-life planning is something that should be done early and often. Okay. Again, here this just recaps why this planning is so important. Dying older adults suffer from a variety of major problems that stop them from making their own decisions. And again, as I pointed out earlier, without planning, there's a heightened risk of unwanted or futile medical treatments. And in fact, there was a study that came out this week that says something like 15 to 20% of medical treatments received at the end of life are futile. And what do we mean by that? Futile treatment is considered treatment that maybe treats a symptom, maybe helps you breathe a little bit better, but it doesn't help the overall body and it doesn't sustain lifespan. So what you're often doing is kind of putting a bandage on one symptom, but you're not enhancing overall quality of life, and you're kind of stringing people along beyond what some would deem a healthy and worthwhile and pleasant life. End-of-life care that is extended over very long time periods is very expensive. It's also a source of psychological duress, again, watching a family member die. But again, the point I keep coming back to, it's important to do this planning, because if you don't, those decisions are going to be left to children or to spouses or to siblings who might not know what the patient wants, or they might disagree with one another, and they create, again, a lot of difficulty both for the patient and for the full family. So again, just put a couple specific labels on some of the outcomes I'm looking for. I've been telling you so far what advanced care planning is, but there really are a couple main components. The living will is what specifies your treatment preference. Your DPAHC is the person that you name to be your advocate. Those are two things that, two policy levers that actually you all may have had the opportunity to do already. Due to the Patient Self-Determination Act, passed in 1990, it's required that all federally funded hospitals and nursing homes give patients the opportunity to execute advance directives. So all of you have the opportunity to do this, but not everybody does. Only about 1/3 to half of all Americans actually engage in this behavior. And just to put it in context, if you go to the hospital, is that really, and you're all stressed out, is that the moment you want to be doing this? You might not have your family members there with you. Just to tell a personal anecdote, a few years ago I broke my ankle and it was bigger than my head, and they took me to the hospital, and like the second question they asked after insurance card was, do you have a living will or advance directive? And I sheepishly said no, but I study them. And partly, I was 35, I had a broken ankle, I wasn't going to die. But think about that, I was 35 at the time, but even if you're 75 and you go in with a coronary event, your head is not at the place that at intake you're going to sit down and think about these issues. So the opportunities are there to do these things. Everybody has this opportunity, but often the time in which they're invited to do so is not a time that someone's in a place to make that kind of decision. Again, but given all this talk that we need living wills and we need DPHCs, there's a lot of evidence showing that those documents alone don't always work. You might have a living will, but it's in your freezer where some people keep them, or it's in your safe deposit box. It's in New Jersey, you're in Florida. When you have a heart attack, it might not be of value. So again, on the whole, it has value, but it doesn't always get used or implemented in the way it's intended. So as a result, we also encourage people to just have informal discussions, not legally binding, but sit down with your family members. It's usually advised to do this around Thanksgiving, and talk about what are your preferences. Telling a loved one, again, if I'm ever a vegetable, pull the plug, that has no clinical translation. You need to have conversations that are a little bit more complete. But what I do want to convey here is that just family members generally knowing one another's orientation toward wanting treatment or not wanting treatment, what they consider a life worth living. These values are important to convey as well, because they help, again, the family unit to come up with a decision that's ultimately good for both patient and family members. So this, again, is what we are supposed to do, but very few people do it. Only about 1/3 of older adults today, anywhere between about 1/3 and half, have a living will. It differs by samples. And if you don't, you're at risk of receiving those treatments that you don't necessarily want. So these are the components, or what people are suggested to do. And I'm going to make the case that whether we do these things, with whom we do these things, are very much shaped by our family relationships. These are things we tend not to do in isolation, and the extent to which we do them and who we engage, who we appoint as our decision maker, might be related to the quality of our relationships. Again, just as so many other health behaviors are linked to the quality of our relationships. So that leads to this next slide of how is it that families shape advanced care planning. This just recaps some of the points I made earlier, but I think we can think about this as really a proactive health behavior that we do to protect ourselves from unwanted treatment or wanted treatment we don't get, as well as family members from distress. We know that family relationships protect our health and our health behaviors. As mentioned earlier, not all relationships are equally protective. Marriage more so than cohabitation, good marriage more so than bad marriage. And you'll hear more, I suspect a little bit later, about why and how it is that our family relationships bolster our health. But one is pretty straightforward. It's social support. If we feel that we matter to people, if our family members love us and make us feel encouraged, we might be more willing or able to take on a health behavior that could be challenging to do, especially something like end-of-life planning. Even those of us who think about death 24/7 as part of our job, thinking about our own death, thinking about our family members' death, that's a difficult place to go to. And again, that cushion of feeling love and support sometimes emboldens people to think about these matters. But then by the same token, Deb Umberson and a couple of other folks working in this area show that our family relationships are a social control mechanism, that our family members make us do the right or healthy thing. So, again, I study widowhood, and we know that oftentimes if a wife dies, her husband will die shortly thereafter. And it tells a very lovely romantic story of this man dying of a broken heart. But, you know, the data shows not necessarily that. It means the woman who gave him his healthy meals and gave him his heart medication every day is no longer there to keep him healthy. So again, there's a social control perspective, and having a loving spouse or child say, now you need to do your living will now, might, again, push along the process. So our family members control us in a way that is good, although sometimes it can be annoying. And then likewise, they give us support. So again, the feeling that we can and should do these things that protect our health because they help us in the larger family unit. So those are the ideas that underlie this talk. Again, lots of stuff, but we'll hopefully come up with some good answers soon. And just to go through the research objectives, I'll show you some slides and some tables, and we'll talk results, and then we'll open the floor to Q&A. Again, first, a very straightforward question. How do marital equality and parent-child relationships affect whether and with whom one does advanced care planning? That's from the New Jersey end-of-life data set, which I'll tell you about in a minute. And secondly, what kind of planning do you do? Do you do just the legal documents or also have conversation? That matters, because if someone fills out a living will on their own and they never show it to anybody else, probably not going to be helpful. And that might actually be the kind of thing you do if you have really lousy relationships with your kids. I'm going to write a living will and I'm not going to tell them what's in it. You know, you could imagine these kind of things happen. That's not very helpful. But rather, if you do just formal planning, not always the best thing, but if you do it in tandem with the conversation and you work on it together, that's considered kind of the ultimate outcome. Then who do you choose? It's an interesting question. You know, people ask me this, and reporters ask all this time, often, all the time. Who do you ask? Who do you ask to be your advocate? Is it the person you're closest with? Or not? And just to give one anecdote, you know, sometimes you're in the newspaper commenting on something, then you'll get these random letters or phone calls from strangers. Some of you as academics know this. And I was quoted in the paper something about advanced care planning, and I got this long impassioned email message from a woman in, I think it was Ohio, not Indiana, and she didn't know me from Adam, and she emailed, she's like, I'm so devastated. I am my mother's closest. I'm her best friend. My mother I know loves me best, but she asked my sister to make her decisions for her. And why is that? And again, her pain was just palpable in the course of this email. And I said, well, sometimes you don't actually choose the one that you love most. If they're too attached to you, they might not be able to make the hard decisions. Sometimes it is the more practical child who is, Jill stuff, who might not necessarily be the warmest child. We choose children and family members to do things for a specific reason. But I think also it's important to figure out, how do the quality of our relationships and with whom dictate who it is that we choose, that we bring into this very difficult role. So that's something else I'll show results on. Then the next question is, to what extent do married and cohabiting people differ with respect to their advanced care planning? We know that married people tend to have better health and health behaviors, but why? Like, why is it that cohabiting relationships do not push along the same positive health behaviors as marriage? And some of you probably can think of the answer now. If you fall asleep before I'm done with this talk, the answer is the relationships are less stable. If there's someone you're with who's in the fine for now category, you might not be actually thinking about them by your bedside in another 20, 30, 40 years. So again, it's not just the structure of the relationship, but what we imbue in these different structures, whether it's a shared future orientation, a sense of commitment, what have you. So that's, again, analysis based on the knowledge networks. And then, do these patterns, why is this happening? Why is it that we see cohabitors not planning as much? Is it really due to something about the relationship? Or again, getting back to our causal discussion earlier, is it something we call social selection? Sometimes it looks like we belong to a social category that kind of brings us bad things. On average, cohabitation is worse for us than marriage. But then you step back, what kind of people are cohabiting? They tend to be younger. They tend to have less money. So again, is it something about the relationship or something about the kinds of people in those relationships that either impel us toward or take us away from a particular behavior? So that's one of the secondary aims here. If we do see a difference between married and cohabiting people, why is it? The relationships or those things that get us into the relationship? So all kinds of stuff we'll be talking about. Before I go into data sources, does anybody have questions on any of the core concepts or ideas? Oh, good. I just needed a sip of water. Sorry, I'm coming down with the cold. So data sources. Many of you are expert data users. I know we have Midas and HRS and N-Shape people in the room. There are a couple more data sets of aging, a couple of which you'll learn about today that I've done these studies on. Just to give a little background about how this happened, before I started doing this, there were very few surveys that asked people about end-of-life issues at all. I think there was maybe one survey. And when I was a grad student, I worked on the Wisconsin longitudinal study, and I stayed with it. And I was very, very fortunate that the PI of the study, Bob Hauser, was very open to letting his graduate students write questions for the survey. So back about 10 years ago, I wrote a series of questions about end-of-life planning. Just, do you have a living will? Did you appoint someone as your advocate? Who is it? Why did you do this stuff? And luckily, I was able to get those questions on the Wisconsin longitudinal study, which is a sample of a total of about 10,000 men and women who graduated Wisconsin high schools in 1957. So they're now 70 years old. So it's a great, huge sample of white people of a particular cohort living in Wisconsin. And so I was able to answer some really interesting questions with that data set. But it dawned on me that our whole nation is not tall, white, conscientious people from Wisconsin. We have a much more diverse society than that, so I went and got some money, fortunately, from NIA to replicate aspects of that study where I am in central New Jersey that has a tremendous racial and ethnic diversity. So I have a much smaller survey on end-of-life planning that has good numbers, reasonable numbers of blacks, whites, Latinos, and Asians. So I could really look to see whether the processes that we see going on among white Wisconsinites can be replicated elsewhere. So those are two papers that just came out in Journal of Gerontology, and I'll walk you through the findings of those. The good news is even though they're totally different samples, the results are pretty much similar, which is nice. It shows that there are some general human principles, and you'll see what those are. And then finally, my marriage cohabitation contrast paper is based on a survey called Knowledge Networks, which is one of these national surveys of, this was a very interesting one, of couples. And the design of this study was really to find out how do couples meet, what helps couples have good versus bad relationships. But they had a module competition, so people could submit modules, and I sent in some questions on end-of-life planning to figure out how do couples negotiate this, especially if they're not married, especially if they're young, are they even thinking about these issues? So luckily, they took my questions. Again, all the stuff you see here is because I'm very fortunate to be supported by really good, nice people who give me money in survey space, and so I'm able to do this work. But again, this is a way to look at kind of younger people in couples. What are they thinking when it comes to their future? So those are the data sources. Outcome measures, again, I try to use the same outcomes in all of the different data sets. The outcome here is just advanced care planning. Do you do formal and informal, which is considered the best, the legal stuff and the conversations? Conversations only or none? None is considered the worst. And then also, who do you choose as your advocate? Do you choose nobody, which is the modal category, your spouse, your child, or someone else to try to figure out how these things go? How do I get at family relationships quality? Again, do you plan with people that you're closer to or not? I use a couple of different measures. One is overall family functioning, just to get, does a family make decisions together? This is a 10-item scale, and so it's a composite of items such as in times of crisis, we can turn to each other for support. We're able to make decisions about how to solve problems. Again, you would think that a family that functions well and makes decisions well together might be more likely to do this kind of planning. But then we also care about relationships with specific people. I want to know, do you choose your spouse when you have a good relationship or when you have a bad relationship? So I want to know your relationship with the specific person who you might be naming as your advocate. So again, the positive and negative interaction scales that capture how it is you get along with your spouse and how you get along with your child. And these are probably familiar measures to many of you, the positive and the negative. So again, in the interest of time, I'll just kind of summarize a couple results. First, for the New Jersey end of life. I have the tables up here, but I wasn't sure how big the room was going to be. The font is small, so I'm going to stay away from the tables, though you can look at them if you like, and focus just on the findings. In my New Jersey data, what do I find? That people with better functioning families, those families that got along better, they're almost they have about 3 times the odds of discussing their end-of-life plans, and also of doing the 2-pronged advanced care planning. So on average, you can say those families that function better are more likely to do the 2 most effective types of planning, those types that involve conversations, either conversations alone or conversations with the legal documents. But again, that suggests that planning is happening among the people who might actually do fine in the end anyhow because they make decisions well together. What else do we find? That, again, if you're a married person and you can name your spouse, you can name your child, you can name someone else, maybe a sister, neighbor, you can, on average, you tend to choose those who treat you well. So if the more emotional support you get from your spouse, the higher the odds you turn to your spouse. So again, if we have a spouse that never listens to us, who seems kind of like a jerk, we don't appoint him or her to bring him into the fold. We just leave him by the wayside. Like, you know, you go with your spouse if they treat you well. If you have a spouse that criticizes you, you're far less likely to choose your spouse, which means you're more likely to turn to someone other than your partner. And again, I think this speaks a lot to the theme of the conference here of our relationships over the life course definitely shape how we behave. And think about that. If you're the spouse and you're not the one in the decision-making position, that's a pretty profound situation to be in. Likewise, when it comes to kids, this was kind of an interesting finding. I think it'll be interesting to people in that corner of the room. I find that people who get more emotional support from their children are more likely to appoint a child. That makes sense. If you're close with your children, you're more likely to appoint them. But there's also a funny finding, also higher levels of criticism for a child, from a child, meaning your kid always criticizes you. It makes you more likely to choose a child as your advocate. And so some of you might be thinking, is it a child that just like browbeats you into choosing them? You must pick me. No, what it is it's a function of how these things were measured. The questions are, how do you get along with your children? And our interpretation is that if you have one child that criticizes you a lot, where are you going to go? To another child in some case. So again, we don't know exactly why that is, but I think in this new Wisconsin study I'm doing, I'll be able to really get at individual level family relationships and how they help you. And we know sometimes there might be conflict with one child, which means the relationship with the other children are strengthened all the more. Again, some of you might be nodding that you have kind of good kid, bad kid. There are some kids you turn to for some things and not others. And that might be what we're seeing there. So it's not necessarily that you choose the child that criticizes you. It's there is a child that criticizes you in the family, and then you turn to another kid to take on that responsibility of decision maker. Okay. So again, that's some of the main findings with the spouse, the good relationships, you bring them into the fold. With the children, the good relationships, you engage them, or you also engage a child as a way to fend off the negative behavior from another child. Now that is too small. Okay, so we're just going to skip the results. These are just results if anybody wants to see them. So again, on the whole, we can see for both New Jersey sample, and again, I have almost exactly the same results for the Wisconsin study. It is the good relationships that foster planning, okay? And just to foreshadow one of the policy implications, you know, this suggests, again, if we now really try to force people to do end-of-life planning, will it work on people who have bad relationships, or is it the fact that your relationship is already strong the issue that's going on here. I think we have a partial answer that says, yes, that might be the case. We don't know that kind of requiring as a policy intervention people to plan is necessarily going to be good if they're forced to do it with family members who might not be on their page. So again, there's something we can talk about later, but I think there are implications for policy and practice here. So now we can kind of switch gears a little bit to that next question of the married cohabitation gap. Okay, so this is data from the Knowledge Networks panel study. And these are just, for starting, just straight bar charts, just to get a sense of what the magnitude is like. And so the red bars are cohabiting people, the blue bars are married people. This is a sample of 18 to 64, and some of you were thinking, why are we studying cohabitants? It's a bunch of college kids. No, that's not the case. One of the most rapidly growing groups of cohabitants are older adults. And we know that with high levels of divorce for baby boom cohort, and gray divorce, as Susan Brown calls it, we have large and growing numbers of couples in their 50s and 60s who are romantic partners who maybe are not legally married. And they're cohabiting. In some cases, they live apart together, meaning that they live apart, but they're very much a committed couple. And perhaps they might be thinking about one another as potential end-of-life planning partners. So again, cohabitation is not just for kids anymore. In fact, it's something that's becoming grayer and grayer each coming year. So again, this is an important population that we need to consider when it comes to a variety of health and health-related behaviors in later life. But to give kind of the quick answer here, what's going on when it comes to end-of-life planning? Let's see. So here, this bar chart over here is kind of whether you do no planning, formal only, discussions only, or both. That's kind of the legal aspects. Over here, it's who do you choose? And a couple things that should jump out at you, because these are young people, so not that many of them planning at all, but cohabitants are far more likely to have done nothing, and they're less likely to do the two superior forms of planning, discussions or both. So again, you can take away the point that yes, it's those in legal partnerships are more likely to do planning. And then likewise, if you look to see who are they choosing, this is really interesting. Again, most people choose no one, but married people are far more likely than cohabiting people to choose their romantic partner. And again, that's a teeny tiny amount. Think about this person you're living with who is presumably love of your life, at least for now. Only 10% are choosing that person to kind of be the one by their side that helps them at the end of life. And I think that again, might be another interesting indicator for those of us who are interested in marriage to get a handle on what happens in a marriage and what future orientations mean in a marriage. But you can also see the cohabitants are more likely, again, those are small bars, but that's a significant difference. They're much more likely to choose someone different altogether. You know, who are they choosing? That's an interesting question. So that's the sheer pattern data, but why is this, okay? And so again, the next chart is too small for many of you, so I'll just kind of set it up here. So we always want to figure out what's going on here. Are the cohabiting people not doing end-of-life planning and not engaging their partner? Again, because of these selection factors, maybe they're younger on average. If they're young, they're healthy, they're not thinking about this at all. Or could it be that this is the relationship that's considered fine for now? Maybe you don't see your future with this person. So what we did next is we took all the cohabitants in our study and we broke them down into different subcategories. We know that cohabitants differ. There are some who are together for now, you know, and you expect it to end. There are others who are in it for the long haul, who intend to marry. There are all different stripes of cohabitants. When you glom them together in any kind of study, whether it's a health study or a health behavior study, we're going to have an incomplete portrait. So that's the next place that we went to here. Now that is too small for you. Yeah, so what I think maybe I will do, oh, I'm doing the wrong way, is I will summarize the findings here. Again, it's a lot of numbers. I don't know how clear it is, but I will cut to the chase. When we broke down cohabiting people and put them into different categories of those who were cohabitors who planned to marry, cohabitors who didn't plan to marry, again, I have a bunch of tables here, but I'll just kind of cut to the chase here. We actually see that cohabitors who plan to marry, once you control for everything else, especially age, they don't particularly differ from married people. So cohabitants who plan to marry their partner are just as likely as married people to do the planning and to engage their partner in the planning process, okay? we'll put here, but of cohabiting people who do not intend to marry their partner, there is a huge gap. The cohabitants who don't plan to marry their partner are far less likely to do any kind of planning, and the main explanation there are a couple of variables that are built into our models. It's commitment to the relationship and quality of the relationship. We ask them, how likely is it that you'll still be together? What is the quality of the relationship? So again, the reason cohabitants who don't plan to marry are not naming their partner as their DPHC or engaging them in planning is they don't see a future with this person. I think this is kind of perfectly sensible and perfectly plausible, but I think it's a find that we might want to carry over into our other studies of health and health behavior. Maybe cohabitants don't make us behave as well as a spouse would because we don't have as much of a vested interest in a cohabiting partner who we don't particularly see a future with. So that's less of kind of a public healthy message, but more for a message for the family researchers who often use a big fat category of cohabiting versus married, but forget all these gradations therein. And if you glom them all together, you're going to have results that are not very crisp and perhaps not very accurate. So those of you who are cohabiting with a partner, figure out tonight whether you think you're going to stay with them forever, and then go do some advanced planning. If not, just keep your eye on someone else with whom you do see a long-term future who will probably be a good advocate for you at the end of life. But all of this suggests, again, that the way that people involve their family members is fairly rational. You turn to those who support you. You turn to those who will probably make a decision that is consistent with the decision you want. And you do early planning now with someone who you foresee down the road in the longer haul. So again, it all gets back to that main point. If we don't die alone, we die with those people who are nearest and dearest to us with whom we envision a long-term future. Because even older adults in their 80s or 90s sometimes envision that death is not until far off. We don't like to think about death. We push it off into the future. And so we like to think only about very long-term persistent relationships as being those that will kind of protect us through the dying process. So those are all the findings that have been collected thus far. Again, I'm happy to talk about any of them in detail and try to make some of the numbers bigger for those who are so inclined. But I just want to give kind of a little advertisement of this other project that I'm really excited about that will help us to answer questions that we haven't been able to answer thus far in end of life. And so, this is a spin-off study that I did called the Wisconsin Studies of Families and Loss. And if you remember earlier, I told you about the Wisconsin Longitudinal Study, which is a survey of all the men and women in Wisconsin who graduated high school there in 1957. They're now in their 70s, and they are dying. And I know from our surveys when they were alive who did advanced care planning. I know everything about their lives, and so I thought it would be really cool as a bereavement researcher to find out how their family members adjusted their death based on all the stuff we know about their lives, but more importantly, to get multiple perspectives on what are conflicts in care, what happens at the end of life, and more importantly, if there are conflicts in care, what does that mean for the family dynamics down the road? Again, I'm sure every single one of you can think about either in your life or in a friend's life some conflict that happened, whether it's over a spoon, who inherits the spoon, or on the deathbed, or alternatively something much more profound about the end-of-life decision-making. So what we basically do is after these Wisconsin longitudinal study participants die off, I do this big tracing. We locate two next of kin. In most cases, it's a spouse and a child, but in some cases, they're single people, so it'll be just a child, just a sibling. And then we interview these next of kin about the conflicts about end-of-life care. Did the living will work? Did it create problems? Were there disputes over who was named as the DPHC? What was the death like? And then also, how were you all doing, and how were you adjusting to this death? My target sample size is 1,450. We're a little more than halfway there. We have 743 interviews completed. Some of you, including NIA, will say, why do you need so many people? It costs a lot of money. Well, part of the reason why, it's a study of individuals, but the unit of analysis is really the dyad, and I want good numbers of different types of combinations. And especially those people who are in kind of what we consider, atypical family relationships, unmarried people or childless people. It's going to be, we need a good sample size. So if you're an unmarried childless person, maybe it's an interview with two siblings. But I think there are a lot of people who are aging today who do not have by their side a spouse or children. Even though this is a conference on families, there are increasing numbers of people who do not have those traditional family members around them when they die. And I think we really need to know what their challenges are of aging. So this is just a little sneak preview. This is how the individuals fall out. The individual people interviewed, this is how they relate to the decedent Okay, most of them are spouse, partners, or children, but this gives you a sense of when I have combos of respondents, this is who they are. So not surprisingly, the majority are spouse, child, 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 and we go down to other, which could be something like neighbor, neighbor, friend, friend, and so that's where we're going now, and I have all this data to mine that I'll be talking about at ASA, but this will help us again to figure out, does planning help? We can study that prospectively, and for whom? Do we get multiple competing perspectives on this? And I think this is the important question of, does end-of-life planning help or hurt, and for whom? Again, this is a contested topic, I recognize that. Whoops, I keep going the wrong way here. There are real implications for policy and practice here. This whole notion of end-of-life planning being a bad thing was something perpetuated by Sarah Palin a couple years ago. I'm in Indiana, so maybe some people do like Sarah Palin here. But as you might know, just to give this, why this is so policy relevant, I keep hitting the wrong key here. Some of you might know, as part of healthcare reform, a couple of years ago, Obama proposed that part of the, as a Medicare beneficiary, there are a bunch of stuff you get, right, a bunch of benefits. One was just a really simple benefit, was that all Medicare beneficiaries would get one kind of paid for doctor-patient consultation session regarding end-of-life decisions. You, your family members sit, talk to the doctor, it gets the conversation going. You can say whatever you want. You can say, give me everything, give me nothing, but it was just simply getting that visit paid for, right? And what happened? There was a whole uproar. Oh my God, this is going to lead to death panels. If you talk about death, they're going to kill a grandma. And so as a result, he pulled it the next day. And who knows what's going to happen with healthcare reform now. But it seems like if you make a benefit available to people, you give them that session. Even those perhaps who don't have the most supportive family relationships, if they get in there, they start talking in a mediated discussion, perhaps with a healthcare provider, maybe it'll make some incremental benefit, again, to ensure that people receive the kind of care they want and they die in the way that they want to die. Again, and just another point again, these kind of policies might be most effective for those who are in the greatest need, and that's often our goal with public policy. Happy, healthy, rich people with lovely families, probably don't need help. But those who have tenuous family relationships might be the one who benefit most from an intervention or a policy of this type. So I will leave it at that, and then we can do maybe 7 minutes or so of questions. So thank you. Yes, sir.
Question time. Is it time to ask questions? Yeah.
Please, yes.
Regarding the advanced care planning, what if someone regrets the decision made 30 years ago and is incapable of making a new decision because of health concerns presently? Is there research showing the consistency of decisions over time?
That's an excellent question. And the one kind of mantra of advanced care planning is this is something that people should do early and often. Even if you do your living will now, you should be encouraged to continually change it, and especially continually change it as your health changes, but just as importantly as your family relationships change. If you get a divorce, no, you're not going to name your ex-husband as the advocate. The problem is if someone should have a change, they don't take their ex-stepchild off, and then they develop severe cognitive impairment and they can't do it for themselves. That is one of the really tricky situations. And you'll hear stories from healthcare providers about how it's really done. And they do say that sometimes, regardless of what's in the written document, if you have a chorus of family members sitting in that room saying, do A, and the document says B, sometimes they will lean toward what the family member is saying right there. It's hard because there's what legally people are supposed to do, but then what kind of decisions are made in the actual dynamic of the hospital room or the hospice room. So again, if you're kind of stuck with something that's irrelevant even in some points, it's not going to be brought to bear. Kind of the more current information and people will be brought to bear on that decision.
What have you done in terms of how this is sort of reshaped by widowhood? Because if typically people are selecting their spouses, and then they become widowed, I would think there might be a big lag during which they wouldn't change those arrangements, yet now they don't have someone who's alive who can fill this role. How quickly do widows tend to begin reshaping their advanced care planning to include children as opposed to spouses?
That's a great question. I don't know if there's any data on kind of the effect of spousal loss on the change of given that you have one, but this comes about in a couple of different ways. Just a couple facts that inform this question. One is that I've done other papers where I look to see like gender differences in who you choose. Married women are much more likely than married men to name their kid as their advocate. And it's because women know they're going to outlive their spouse. And so sometimes at the outset, the women are more likely to tend to choose a child as a way knowing that they're going to be widowed. Another issue is that often people who have not done planning at all, which is for some age groups the modal category, other people's deaths trigger their own planning. In fact, I just had a little paper in the Gerontologist about that. If you ask people why they plan, the most common thing is my doctor said I just had a heart attack. But the second thing is my husband just died and I don't ever want to die like that. Or I saw my mom die and I never want to do that. So sometimes actually a death event, especially seeing a bad death of another person, kicks us into gear. But that other question, I don't know the answer, and if anybody should know the answer, I should. I think it's partly because I could look at it, but we'd have very small cells, right? That time period of recently widowed and then whether they changed their planning. So no one really has good data on it yet. And maybe this is something, when we study these things, we talk to like lawyer audiences from time to time and financial planners. This is something the lawyers need to know. Unfortunately, when they're sitting with the sad widow and talking about the dispersion of property, they probably should say now. Now is the time that we really need to redo your living will. But excellent question, excellent point. Lisa.
I'm interested in your wistful study that you're working on, and just wondering if you can tell us a little bit, if you've looked in how you approach families and what the response has been to these family members being asked to participate on this topic.
Good question. This is, yep. Oh, I'm sorry. I'm usually good at doing that with my big undergrad course. So to repeat Melissa's question, she's asking kind of about the practicalities of doing a survey like the Wistful, that you're going to a person that they kind of knew that their loved one was in Wisconsin longitudinal study because they get so many mailings from us, but then to come in and say, hi, we know your partner died and we're going to ask you questions about it. Honestly, of all the surveys I've done, it has been the single hardest to get a good response rate. And designing this study was very difficult because there were two different ways I could have done it. One way I thought was more logical, the other, and I thought was more logical, that for the Wisconsin longitudinal study, I mentioned all these graduates, but we also have parallel interviews with a spouse and with a sibling from years back. And my thinking is those are the ones we should target, the spouse and the sibling upon whom we have all this life history data. So I have the best kind of correlates of their reaction. But then in practical terms, I really should be interviewing the two next of kin who know the most about the death. And that's exactly how we did the screening, that for a person who died, I knew from 50 years of data who their spouse and kid was. So we called them first. And in some cases, they were kind of like taken aback. How did you know? But then we kind of explained what the study was. And then we asked them, are you knowledgeable to talk about this death? And for spouses, almost always they said, yes, I am. But if they said no, or for any of them, we would say, can you tell me who else in the family could talk about this? And so that calculating our response rates is just a nightmare. So if they said, no, I can't talk about this, but my daughter Judy can, then we go to Judy. And they were surprisingly good about giving us the name of another family member to contact. Sometimes they would say things like, well, let me check with her first. But it was difficult. And usually, again, another thing in bereavement research, we'll never go in for an interview any fewer than 6 months after the death because it's considered too difficult, right? They don't want to talk about it yet, but we're now supposed to go back on 12 months because it's an anniversary and they might be symptomatic at that time. So it was timing issues and then kind of getting a good response rate. In some cases, we couldn't do two, and that's fine. If it really is someone who has only a spouse and no children, no sibs, that's what we went with. But it was difficult. And another thing we did, and maybe too technical for some of you, we sent them all an advance letter. So we didn't cold call them. We sent them a letter with my cute little logo that someone designed. I sent them a link to the WLS, the main study, so they could see all the respondent reports. They could see it's University of Wisconsin. This was something to be trusted. We have a 50-year history. But bereavement studies are hard, and contacting people and saying, yeah, we know this guy died, talk to us about it. That's a tough sell unless you have like a 50-year history as we did with this project. Great.
How much is
sorry.
due, How much is due to efficacy? Because not everyone knows about how to go about DPAHC. So what are the demographic differences? Because there's so much disparity in health knowledge.
Yeah, there's a ton of disparities, and be totally self-serving. And for efficiency, if I have a website and you can find a bunch of papers there, but I'll hit the high points here. I had thought that personality measures would predict this, specifically kind of conscientiousness. It didn't have any great effect. It could be that, at least in the Wisconsin study, they're all very educated and very conscientious, so it's really a non-normal distribution. The biggest predictor I found, and again, this totally speaks to policy, it's not physical health, it's not gender, is socioeconomic status, and specifically not education, assets. I found that people who own homes, who have lots of assets, they go to the lawyer to write a will. Why? They have assets to protect. You go to write a property will, they say, hey, by the way, have you thought about a living will? So there's a huge class story here. And there are vast numbers of Americans, African Americans and poor people who have no assets to protect. They're not going to the lawyer, so they don't have that initial point of contact where the end-of-life planning actually gets kicked off. And so again, another recommendation is to try to kind of hit people where they live, bring more of these lessons into churches or community organizations, but there's definitely a class issue here, and far less psychological. I had thought it would be kind of a planfulness thing, and not so much. Another is, what's the other one? Religion is an interesting one. That I thought it would be your standard, Protestant, Catholic, etc. No, it doesn't play out that way. It's religious people who are fundamentalists are far less likely to think about death, talk about death, do planning, which is kind of interesting. And I think they suspect that maybe it's in God's hands, right? We don't need to do this planning because God decides when it's our time. So funny ones. I didn't expect those to be the core predictors. Mm-hmm. Oh, sorry, I'm chatty. Okay.
This has been great.
Okay.
I have the pleasure of introducing Dr. Karen Hooker today. Dr. Hooker is professor and co-director of the School of Social and Behavioral Health Sciences at Oregon State University. She is the founder of the Center for Healthy Aging Research at Oregon State University and is the inaugural Joe Ann Leonard Endowed Director of the center. She received her PhD from She received her PhD in Human Development and Family Studies from Pennsylvania State University and held appointments at Duke University and Syracuse University. Memberships include the Gerontological Society of America and the Division 20 Adult Development and Aging of the American Psychological Association. Dr. Hooker was the recipient of the Association of Gerontology in Higher Education Distinguished Faculty Award in 2010 and won the Kalish Innovation Publication Award from GSA in 2005. She has been a scientific reviewer for the National Institute of Health and the National Science Foundation and has served as an associate editor of the Journal of Gerontology, Psychological Sciences. She's currently leading an NSF-funded integrative graduate education and research traineeship program in aging sciences and is the first program to have aging as the focus. Her research focuses on the role of the personality system and understanding health and social relationships with methodological emphasis on process-oriented micro-longitudinal approaches. And just for fun, Dr. Hooker enjoys kayaking and exercising her vocal cords as part of a women's singing group and loves to spend her non-researching hours with her spouse and 2 sons. So please join me in welcoming Dr. Hooker.
Yeah, right. Okay, I wanted, first of all, to say thanks again for inviting me to be here, part of this symposium. I just think it's I've heard about it for years, and I think it's such a great idea, and not only hopefully will people in the audience learn from us, but I am really learning from the other presenters as well today, so we really appreciate that. And I also want to say thanks to Karis for coming and getting me at the airport so late last night. I know you have that was really sweet of you, I appreciate it. Okay, so a very brief overview here is that I'm going to talk a little bit really more about the personality system and how it may play a role in influencing our social and health behaviors in later life, and talk a little bit especially about something that I think really underlies health behaviors, and that is goal pursuit. How do we go about pursuing our goals? How do our goals help make us who we are, and then how do we pursue them? So now for something completely different, I am going to take an intra-individual variability approach to this. And of course, the projects all do have to have cute little names. So my project is called the Pulse Project. And then I'll end with talking a little bit about future directions. Okay, so just some brief acknowledgments to my collaborators. On top are my students, some IGERT students, and on the bottom is the Pulse team. and this has been funded by supporting students from NSF as well as the Center for Healthy Aging Research. And I also wanted to acknowledge my student Shannon Mejia, a doctoral student who was very centrally involved in these studies that I'm going to talk about today, and especially the analytic approaches. Okay, so I thought I'd start to talk a little bit about personality and aging. And if you think about it, much of what we really know about optimal aging is focused on the lifelong importance of health-related behaviors such as exercise, not smoking, eating in moderation, drinking in moderation if at all, being actively engaged in life, and having a really strong social network. And other known predictors of what makes for good health span are things like education levels, socioeconomic status, and social structural variables, serving as kind of risk factors. Some other variables are gender and race, but surprisingly little really is known about the person in whom these risk factors cohere. And in fact, I would argue that personality is really the driving force behind many antecedents of successful aging, except, of course, those structural variables. So, what type of person you are? How reliably can you be counted on? Your approach to people. All of these are really centrally involved in how we approach our health, how we approach our social relationships, and our health span. I think part of the reason why personality hasn't been really looked at that much is that it wasn't until recently seen as a construct that was open for, it was seen as too rigidly stable, and it wasn't really seen as open for intervention. However, we know from more recent work that personality, in fact, can change throughout the lifespan, and the good news is, for those interested in adult development and aging, is that personality, the trait part of personalities anyway, does seem to, if there's going to be some developmental trajectories, be more positive ones. So more towards maturity, maybe a little less hostility and neuroticism and more conscientiousness. So that's another good news, I think. So several years ago, I sort of built on Dan McAdams and his tri-level personality. He talked about traits. He talked about personal action constructs and life story as kind of the structural aspects of personality. And I found this very compelling at the time because the field was really going back and forth between, is personality stable? Does it change? If it changes, what predicts the change? But what I thought was really missing in all that still was the process components of personality. So along with traits, we have states. People aren't the same every day. Along with personal action constructs, which are our goals and can change, but maybe not all that quickly, are self-regulation. How do we go about meeting our goals? And then along with the life story is, of course, self-narration. How you tell the story about your life, who do you tell it to, and we know, for example, from some of Cynthia Adams' work that it changes depending on the context and the audience. So today, this is the personality system writ large, okay? It's really much broader than we typically give it credit for. It's more than just traits. Today, I'm going to talk mainly about the level 2 personality, the personal action constructs, and self-regulation. Okay. So I thought I was just so happy when Diana Nyad made her swim from Cuba to Florida. I was so thrilled for her. I'm a swimmer. But also I thought, what a great example of goal-focused goal pursuit. We do know that over the last 50 years or so that to a large extent, development is guided by our own pursuits, our own goals, our intentions, goals, motivations, and of course our behaviors as well. So we know development's multi-directional, multi-dimensional, and in fact we are producers of our own development. So Diana Nyad's example I think is a great one. Here's somebody who, talk about tenacious goal pursuit, right? She tried 5 times. The first time in her 20s, I think when she was 29. And then she didn't try again until her 60s. But here she is at 64 doing this momentous task that was very much, it was her striving that caused it to happen. But in addition to building her mental strength as well as her physical strength and endurance, she also built a team of supporters that could support her efforts. Engineers she had to build her specialized suit. She had medical personnel on the boat to tell her if she could keep going. But also importantly, yes, development is to some extent under our control, but there's certainly things outside our control as well, and this is another good example. For example, the Gulf Stream helped her make this swim this time. Previously, the current had sort of taken her out, as well as the fact that there were not as many jellyfish in the water, and of course she had this specialized suit. The point is she adapted to her context, learned goal strategies to make this historical milestone happen, which was indeed very important for her own life story. Okay, so how we reach our goals is partly due to individual agency, but also very heavily also dependent on social context. But what I want to argue is that our social context doesn't just happen to us, but it's something that over time we really create. I don't know if any of you remember back to Carr and McCartney's articles about niche picking. So for example, over time, we may end up in social networks that look entirely different from the circumstances we grew up in due to niche picking, picking our social context and so forth. Now we all know, everybody in this room knows, there's abundant data on how very important social support is for all aspects of our health. And I think many people in this room really have research agendas addressing the mechanisms driving this complex relationship. So I also just want to argue it's important to reflect on the extent to which there are bi-directional relationships between who we are and the social networks that we create. And a somewhat underappreciated factor is personality. So what are these social support networks that we create? Well, I want to talk a little bit about the social convoy model, because I'm going to talk about it later in terms of our research study. But Kahn and Antonucci, as many of you know in this room, created the convoy model to describe how social relationships travel with individuals throughout the lifespan and life course. Okay, and their particular model, it was a hierarchical model where those in the center circle are those who are very close to us, you couldn't live without them. Those in the next layer out are people who are very important, but perhaps not quite as close. And then the outer circle are people that, yes, they're in our lives, we consider them part of our social network, but maybe we don't see them daily or for whatever reason don't consider them to be quite as important. Sorry about that. Let me go up. Go back. Yes, this is what I want. Oh, I'm sorry. Come on, technology. Okay, how do I make this? You're going to be sick of seeing these slides when I'm done here. I'm going to go to escape. Yeah. And then say from current slide. Thank you. Yes. Okay. Okay, so importantly, I think convoys are very heterogeneous, right? They vary certainly in size. Some people have very well-developed convoys, others less so. They vary in terms of composition. Are these mainly family members in the convoy? Are they a mixture of family and friends? Or some people really have convoys that are primarily made up of friendships. So that's an important thing to know and look at. Another point is that convoys themselves are very fluid. I did not touch a thing there, I promise. And so understanding more about how aspects of the individual shape the convoy and are reciprocally shaped by the individual is really important for the investigation. And I want to set the stage for how our research team is addressing this, and so I'm going back to Ray Cattell's data box. How many of you remember this? Maybe some of you in the room do. But basically, Raymond Cattell was a personality psychologist who said that basically for every act, there's a person who does it, there's a variable that defines it, or variables, and an occasion that locates it in time. And what I want to argue about today is that for the most part, most of our research, we've paid almost exclusive attention to sampling people. And there's some other sampling strategies that we can take that might also give us some interesting new information. So, Okay, so I would say that the vast majority studies in HDFS, psychology, sociology, public health, really all the social sciences, take this inner individual data slice, which looks at many people, many persons, usually now many variables, but a lot of times only on a single occasion. Or, increasingly, a longitudinal study would do this several times at widely spaced intervals, maybe 6 months, a year, 2 years, or whatever, so that what the study can really address is mean level changes for the group, okay? That's what it addresses. Intra-individual data, on the other hand, takes this slice of the matrix, in which for one individual, you have lots of variables and lots of occasions, okay? And these occasions can be over many days, sometimes over many times within a day. Those of you who know about experience sampling methods, where people are beeped throughout the day and then report on their feelings and maybe physiological data and so forth. And then seeing how variables are associated with one another for that particular individual over time. And I think this can be quite instructive if we're really interested in understanding how to change health behaviors, how to motivate individual people, because health behaviors, health decisions, support networks, all of these things can be captured at the behavioral signature level of the individual. Now, we need to then, one might argue, is take many of those studies, almost single case studies, group them together. And so then you can get like an idiothetic approach, which is a combination of idiographic, which is focused on the individual, with nomothetic. The nomothetic science is science in general. And then the idiothetic is the combining of those so that you can parse out the individual, but still basically see themes of uniformity across lives, but that still have clarity at the individual level. Okay. When doing this, when we take an idiographic or idiothetic approach and measure people on lots of occasions, we discover some interesting new ways in which people really do differ from one another. For example, people have different ranges of plasticity or variability on variables. The person on the left, for example, maybe that's self-efficacy, and that person's swinging wildly from one day to the next, okay? The person on the right you would characterize perhaps as much more stable, correct? So basically then, the extent to which someone varies on a variable can become almost a trait-like characteristic for that person, something that can be looked at. So people can be described in terms of their behavioral signature of how widely they do vary. And for example, this can be called a dynamic characteristic, where you just get, for example, the intra-individual standard deviation is an example of a dynamic characteristic. You can see for this individual whether they tend to vary a lot or tend to vary not so much. So it's like a range of plasticity, if you will, for that person. We can also look at dynamic processes, which can look at the time structuring of the variability. Are there trends over time? Is there a cyclical pattern to the trends? For example, moods might get better on weekends, but then maybe fluctuate down a bit on Mondays, I don't know. This type of change, for example, would not really be considered development, however. So to characterize something as true developmental change, we need lots of data points to be able to see trends that might be developmental. So an example I'll give here is, let's say your mother just moved into an assisted living facility. And she moved near you, and so you're the one helping her find this assisted living facility, and you find it. And you're very interested in psychological well-being, and so you sort of get a sense of where she is at baseline when she enters the facility at 6 months and maybe 12 months later. Now, you see her every day, but these dots are your brother who's flown in from San Francisco to see her 3 times a year. He sees these and he goes, oh my God, this is a terrible place. Look at mom's psychological well-being. Another way another possibility would be somebody who, on the face of it, looks very stable. That same brother comes, sees the same, she seems to be doing the same on the 3 times he happens to be there and thinks, wow, pretty stable, that's cool. However, if you, the daughter, are there more often and actually see how she is, look at this. If you draw that line on top, it just so happened that you caught her at the high end when she first moved in, at the middle, halfway through, and at a very low end at 12 months. But actually, if you're following that variability, it's very stable over that time. And again, similarly, maybe the one who looks stable isn't really so stable after all if you take a more micro-longitudinal approach and see that indeed there is a lot of variability. However, there is this disturbing downward trend. So that's kind of the rationale about why we need to maybe, for some studies, I'm not arguing every study has to be this way, but an interesting alternative way to do some studies is to measure people many, many times over lots of days to really try to get a handle on their variability. And Neelam Ram and Dennis Gerstorff wrote a very interesting paper about this that was published in Psychology and Aging a few years ago. And they really talk about trying to parse out intra-individual variability from intra-individual change. If you want to see long-term trajectories of change, the argument might be that you can do these little bursts and get a handle on the variability, and then over time, linking it up to longer longitudinal data sets would be ideal. And they talk about this in terms of macro time, maybe over years or perhaps even decades. We have studies certainly that go decades. And micro time over very short periods of time. So the work I'm going to be talking about today is really on the micro time scale. It's over days. And I'm going to call it a micro-longitudinal study, which I was telling Alex earlier today, I prefer that term over daily diary studies. And maybe it's just because when I was like a girl, I used to keep a diary, it was locked, and I'd write. And so that's not what I'm talking about. Okay, so the 2 things I'm going to talk about really are micro-longitudinal studies of health and social goals, health and social goal processes. So the self-regulation of goals involves goal setting, goal pursuit, and goal accomplishment. And a lot of previous research has shown that health goals and social goals are extremely important to older adults. Working towards a health goal we know can help people support positive health behaviors such as proper nutrition, daily exercise, building social support networks is also extremely important for their health. So anyway, the basic questions I'm looking at is how do people go about doing this? How do they approach their health and social goals? So I'm calling this, by looking at health and social goals that they themselves pick and then seeing how they work towards it, this is a way of looking at self-regulation. And self-regulation is broadly defined as the deliberate attempt to manage actions to facilitate positive adaptation. Okay? So, our PULSE team, Personal Understanding of Life and Social Experiences, is it's an interdisciplinary one. Me and 2 of my students who are social scientists, as well as 2 software engineers, computer scientists. And anyway, we needed a customized platform to assess people daily for a significant portion of a year. In looking at health behaviors, if you're trying to look at people who are setting a goal and working towards it, we know from research in health research that it takes at least 3 months to establish a positive health behavior or to make a new change. So we knew we wanted it to be for more than 3 months, and so we thought 100 days would be good. But how do you actually do this? So to our knowledge, so we partnered with these 2 engineers who were wonderful to work with, and to our knowledge, this is the first micro-longitudinal study of older adults that has been conducted entirely over the internet. And because it is, and because it might be kind of hard to maybe think about, well, what do people do? I do have a fair number of slides showing this, so bear with me. Okay, so the goals of PULSE were to capture processes of self-regulation over 100 days, in the regulation, studying regulation in the context of their daily life. So we collected a lot of information on a lot of variables over those 100 days. So I'll show you more in a minute. And we also wanted to be able to identify individual characteristics related to distinct patterns of these social regulatory processes. And the engineers we worked with were also very interested in data visualization. That was their specialty, data viz. And in talking with them, it became very clear to me that this could be a really cool way in terms of health engagement is a big thing now with health plans. I don't know if some of you have to, when you sign up for your health plan now, you have to take this health engagement thing and you have to do all these things online. But we thought, wow, if you could engage people in data visualization of their own data, maybe that would keep them interested in doing it for 100 days. And in a way, I think we found that there were some interesting effects because of that. So the basic design was that people took an initial survey, which was fairly long, and but in that initial survey, they formed a health goal and a social goal that then populated their daily surveys, okay? But it was specific to them. So people could have, we wanted the goals to be meaningful for the person. And then there were these daily surveys, and we were also interested in a methodological question about how much data do you really need to be able to get the behavioral signature. So we had what we called the burst group, which the measurements were over 100 days, but instead of 100 days end on end, it was 4 periods of 7 days, okay, so 28 days altogether. Then we had a post-survey where we got some project feedback. Okay. Okay, so this is just a little bit more information about it. So the initial survey was, we recruited from the Life Registry, which is unabashedly, this is a convenient sample of people who are in the Life Registry, which is a registry in Oregon of adults over the age of 50, who, as part of our Center for Healthy Aging Research, have given us just really their contact information and have said to us, if you have any studies, we'd be interested in knowing about it. So currently there's about 600 people in that Life Registry, and it's people from all over the state. So we sent out an email invitation to participate in this research. And 105 responded that, it sounds interesting, I'd like to get involved. And actually did the initial survey, which was pretty time intensive. After that, 5 did drop out, and 1 we ended up dropping because their data was too spotty. They didn't participate in more than, I think, 8 days, so we dropped them. We found there were no statistical differences in terms of a lot of things you can look at demographically and so forth between those that were dropped and those that were retained. The micro-longitudinal phase, then, we ended up with 99 people who then got randomly assigned into the daily group, so there were 76 people there, or the burst group, 23 people there. And there were no differences between those groups on lots of different variables that we looked at. Okay, so here's the participant workflow. We invited them in, welcome, they did the sign-in, IRB consent, and then they got the initial survey, which I'll tell you about more in a minute. And and between IRB and the initial survey, we did the random assignment into burst versus daily. Okay, so then we could remind them to do the survey, and then the next steps, in that initial survey where they were having to give us some data, one kind of cool thing about doing this over the internet is that you can actually look at the data as it's coming in and determine whether or not they're kind of getting what you're asking them to do. So for example, we had them do a social convoy measure, and one woman, for example, in her convoy, she put her dog, and as much as we would have loved to have kept that in there, I'm sure maybe the dog is very supportive for her. We felt that probably we asked her to put somebody else in instead of the dog. But you can do that kind of a thing. So then people received an email each morning with a link to their survey, and asked to complete it in the evening, and the link itself expired at 2 a.m., so somebody couldn't go in later and do like 10 days in a row. The daily surveys were designed to be completed in 5 minutes. The initial survey was 52, but the daily surveys were much shorter. Okay, so then they get the daily pulse email and the daily data viz, and then this repeats for 100 days or 4 times 7. And we were able to see that because of the timestamp nature of the data, it took people on average 4.6 minutes to do it. So we were able to keep it under 5 minutes. And we were also able to assure that they did complete it at the end of the day. In fact, 83% did complete all of them in the evening. Okay, so the researcher workflow, I don't need to go into this too much, I don't think, except I would like to say that each day the system, it was wonderful having a system that would email us a daily report of the expired sessions, so we could sort of keep a handle on if people were really participating or not. And we followed up with participants who missed 2 days in a row. So we did sort of encourage their ongoing participation. The research did take place in the summer, so for a few people who just said, I'd love to be in the study, but I'm going to, Canada for 2 weeks or something, and I don't know if I'll have internet connection, we were able to pause it for those people. So that was another plus. So the back-end interface, we could see participant profiles, we could see what their goals were, we could see who their social contacts were. Yeah, and then we could see how they were doing. This is an example of the data visualization people got. So, for example, on a scale of optimism, we gave people information on their answer today, so that little triangle is the answer today, as well as their average answer over the days that they had done so far. Okay, so the database obviously built as the study went on, and they could click on different things to find out information. They could hide detail, they could expand it to look more. We considered trying to compare their data to everybody who's in the study, but we decided at the end that we wouldn't do that because there might be some social comparison. People might get depressed if they saw that they weren't making healthful progress, but everybody else was, even though they were all very individualized goals. Okay, so here were the actual measures that we looked at. So demographic information, the things in orange are variables that then went on to populate the daily surveys. So the personal health goals and social goals. We looked at many different things. The NEO-FFI is a trait measure of personality. We looked at depression, optimism, possible selves, self-perceptions of aging, health behaviors, health perception scale. The social convoy, which I'll show you more in a minute, we did ask people to name the social convoy, everybody in it, but then we took the 5 names that were closest in their inner circle and used these names to populate the daily survey and then generated some more questions about those interactions. Then we also had scales of social engagement and a social support appraisal scale. Yeah, so here's the Antonucci and Kahn kind of social convoy measure. There's just a few statistics up there about how many in general were in the inner circle, the middle circle, and the outer circle. Okay. All right, so let's see where they're, and then these are the daily pulse measures. So these were the 100-day measures. So we got their health and social goal progress, which again are populated individually for everybody. Social support and social hindrance, positive and negative affect, stress, optimism, contact with 5 closest social partners, all sorts of things here. So, we asked people also to write down if there were any noteworthy events that day. And so we could maybe go back and look if we saw some trends in the data. All right, so here's how it looked to the participants sitting in their home or whatever on their computer. So rate your progress towards your goal of, and then it would populate whatever the keywords people said that they had on their goals. So yeah, so exercise every day, that would populate every day, and then they rated, I didn't make any progress, I made a lot of progress. And then we use the slider to indicate how well these words describe everything. And note also that there are not numbers on these scales, and we did that purposely because when you're doing things over and over again, we didn't want people to think, oh, well, I usually score an 8 on this, and so just kind of remember that. But the numbers were underlying the database and were captured that obviously we used in the data analysis. The other neat thing about doing it on the computer is that the items were presented in a random order each day within blocks so that there were hopefully no order effects. And so that was another nice feature of doing it this way. Here was our daily measure of contact satisfaction. Okay, so this is microlongitudinal. So please indicate who you interacted with today. And then all 5 people that they listed as their close-in people were popped up on the screen. So for example, Manuel, yes. How did you contact Manuel? And in person, by phone, social media, text, whatever. How satisfied were you with these interactions? Okay? And then it goes on to the other people. So our daily contact satisfaction measure was actually the sum of the satisfaction over the days divided by the number of people contacted that day. So, okay, here is a sample from our study, and I put in of people sort of tongue-in-cheek here, because yes, it's a convenient sample of only 99 individuals, but it was over 7,032 occasions. And as you can see, this is really a young old sample because the average age was 63. It was mostly female, mostly white, pretty well educated, all those things. So definitely not a representative sample. Okay. And I just want to throw out there the idea about, again, going back to the data box from Cattell and thinking about sampling and sampling frames. Yes, if you're going to sample people, this is very much not a representative sample. And I don't know if these occasions are representative either, but wouldn't it be a nice advance methodologically if we could get a handle on, are these occasions representative for that person or not? So, something to think about. Okay, some evaluation. At the end, one of the things people told us, these are just some quotes. One person said, I think it made me more aware of what I wanted and how I could accomplish that or not by being more intentional. It helped some people make connections across domains. One person said, I realized being social made me content. I had always thought I was a hermit. Also, we realized that some things to improve on would be to make sure we have flexible interfaces and that they all work really well. They did work really well across browsers. There were 4 different browsers people could use, but it seemed like the smartphone interfaces were somewhat of a challenge. And one person said 100 days is a long time, but as tedious as it was, I'll readily admit that recording on a daily basis did help me keep focused on my goals. Okay, so I'm going to sort of quickly walk through a few different studies, and we're working on more, but I thought I would just pick out 3. So the first one is really looking at personality traits related to self-regulation of health and social goals. The second one I want to talk about is really spearheaded by Shannon Mejia, my doctoral student. It was part of her master's thesis, and it's looking at structure, social convoy function and social convoy structure and how these relate to each other. And then the last is dynamic coupling of health and social goals, if I have time. Okay, so going back to that 6 foci model I talked about at the beginning, we did try to look at how traits, we were asking basically the question, could daily self-regulatory processes, which we know are important for architecting our lives on a daily basis really, could these plausibly, could they be related to traits? And could these traits then, could this be one mechanism through which traits have their effects on important life outcomes? Because there's, lots and lots of data of how important traits are for many life outcomes. And then we were also looking at variation in relationship to perceived stress. And the reason we were very interested in perceived stress is that a question we're asking really is, can people stay the course with their goals? And it really depends on these self-regulatory processes. Especially in late life, we think that there might be some added advantage of trying to learn more about how people are able to stay on track. We know stress, which we all have every day to some extent, right? Either more or less. But some of Susan Charles' very interesting work is showing that in later life, adults under stress, it might be a little bit more damaging for them. So and it could potentially throw them more off track. So we argue that this does require an intra-individual research design where relationships between traits, self-regulation, and stress can be examined within individuals over time. Okay, So I'm not going to show you all the tables and everything like that. But I did want to just highlight a few things. So these were our predicted relationships of personality to goal progress. People high in neuroticism, and for some of you in this room, this is maybe going to be a review, but we know people high in neuroticism are prone to stress and negative affect, very self-critical. There's lots of data indicating they have worse health outcomes, poorer health behaviors, and in fact, even earlier deaths. Neuroticism's been linked to mortality. Dan Mratzek's done some very interesting work in this area, who I know you guys all know. We predicted that somebody with high neuroticism would have weaker self-regulatory skills, especially under stress, and make less goal progress on their health goals and their social goals. People who are conscientious are task-oriented, plan ahead, they're persistent, they follow rules. I was surprised, Debbie, when you said that the conscientiousness wasn't related to the advanced life care planning. I would have thought that it would have been. But there's some interesting reasons why it probably wasn't. There's lots of data linking in these long-term longitudinal studies that there's reduced risk of illness, people do more health behaviors, and it's related to longevity. There's quite a bit of data now about that. So we predicted that they would have stronger self-regulatory skills if they were highly conscientious, be less sensitive to stress, and make more goal progress on both of their goals. We looked at extroversion too. People who are highly extroverted are, obviously like being with other people, they're high in warmth, they need a lot of social contact, they tend to be optimistic and have high assertiveness. Some of Alex's work has showed that they're more likely to be engaged in positive events. So there's a lot of good things about being extrovert. So we predicted that they would make more progress on their social goals because that's such an important domain. But we didn't make any prediction in terms of health goals because we didn't feel we had enough data to really look at that based on the literature. So the study aims here are to determine the extent to which these personality traits explain between-person variation in daily goal process intra-individually in health and social domains. And then within individuals, do effects of traits on self-regulation become more powerful under conditions of daily stress? Okay, so are the results amplified or magnified, if you will, under these conditions? So the analytic strategy, data were analyzed using a series of multi-level random coefficient models. And I won't get into all the gory details around making the data stationary and all that, but it's in the paper if you're interested. Okay. Oh, and we looked at cross-level interactions as well. Okay, so what does it look like when people are talking about their goals? So on the data survey, now remember this was the time one initial survey, we asked people in the text box to describe the goal you expect to be working on for the next 3 to 4 months, and also why is it important to you? We really wanted to get a sense of these are important goals. And then give us a few words that would cue you in the future every day. Okay, and then those cue words would populate the daily surveys. Some examples of people's goals were maintaining a healthy weight, increasing body strength, eating more vegetables. And just in the terms here that you can see, some people picked maintenance goals and other people picked achievement goals. In later life, we would predict perhaps that people would have more maintenance goals. We actually did not find that to be the case. A lot of people picked achievement goals, and maybe it's, oh, I didn't see the 10-minute warning. Sorry. Okay, so I am going to fly through these. And here's the perceived stress scale. Just briefly, this is a picture of basically the beta coefficients, so that neuroticism people had made lower social goal progress, significantly lower, and health goal progress was also lower, but for conscientiousness and extroversion, on the between-person level, we saw positive associations. Okay, so stressful days were associated with lower health goal progress on that day. Stressful days, both health goal progress and social goal progress. Here's an interesting thing. Adding stress to the model activated neuroticism in the health domain, but we found that, interestingly, holding stress constant, if it wasn't a high day, higher levels of neuroticism actually predicted higher health goal progress. Okay, I'm not going to go into this right now. Conscientiousness. But basically I want to tell you that we think this happens, that people high in neuroticism, we may have discovered something, or at least something to follow up on in longer longitudinal studies, is that people high in neuroticism, they may be sort of like an orchid, that under sort of ideal conditions they can thrive and do very well. But that if you pull them out of their ideal days or whatever, then they're not going to do as well, okay? So that's kind of the orchid, an orchid outside the hothouse doesn't thrive. So that's the metaphor there. Okay, those in conscientiousness, very interestingly, when they tended to have much less stress, but if they did have a stressful day, they tended to make lower progress, okay? So interestingly, something that you might not see in a big cross-sectional study is that when they did have a stressful day, it really harmed them more, it took them more off track. Okay, so this personality under a microscope does reveal these new findings that I think can only be found in this type of intra-individual micro-longitudinal study. I'm not, unfortunately, I should have started with this study, going to get through the relationship and convoy study, but let me just basically cut to the chase here. We were looking at the convoy, as you saw, and here were our study aims. The structure on goal progress, does having a friend-intensive convoy versus a family-intensive convoy make a difference in how people approach their goals? And the short answer is having a friend-intensive convoy was positively related to social goal progress. So we were trying to explain this in terms of why friend-intensive, why not family-intensive. And we think that part of the reason is that, you know, friends are help us emotionally maybe, perhaps more than family members, because we choose our friends, we don't choose our family members. But family members, people are very sensitive to their contact with their family members, at least this older adult group was. So that if they have a poor interaction, and so we were able to look at these interactions over 100 days, and if they aren't satisfied with them, it really sort of upsets them more. It upsets the apple cart more, because, you know, they're your family. You're not going to get rid of them. If necessarily, you could change your friends. Okay, so, sorry about the time. I'm not going to have time to talk about the synchronicity of goals, but I will tell you, I'm going to be talking about this at GSA, so come in and hear. So limitations, obviously, of this type of approach, data are all self-report. The sample was very homogeneous, but even given that it was so homogeneous, we saw a lot of variability. And of course, this sample of people was selective in many ways. So where we're going with this in the future is we're going to insert a burst design into a long-term longitudinal study, specifically the UNC Alumni Heart Study. And I think in the future, this is a very interesting way to use some of the data that we can get from sensors, for example, in studying person context interactions. If we've, you know, there's a lot of these smart homes now, or homes where people are putting sensors in. People are wearing sensors that get physiological data, heart rate, respiration, even how fast you walk. Some of the newer ones even have GPSs built into them. As well as, I think, a web-based portal could be an interesting way to try to in the future, examine and improve people's health engagement around their own goals. So I'm sorry I had to go so quickly through there, but thank you for your attention. So questions? Alex.
Tell us about the synchronicity.
Okay, let's go.
Repeat the question, please.
Oh yes, Alex said, tell us about the synchronicity. Basically, what you saw from these charts is that there was a lot of individual differences between people on how their goals tended to go up at the same time or down at the same time. And what we found was that, okay, so here's examples of weak and strong correlations, but here's like the regressions. And basically, the short answer is that it does promote goal accomplishment. So the blue is the health goal accomplishment, and the red is the social goal accomplishment. And so people who are able to architect their goals so that they can make good progress on both of them, seem to, by the end of the study, make more progress. Yeah. Okay. Jill.
Where did you find any gender differences in these patterns? I'm thinking mine.
That's a really good question. Since we had so few men in the study, we did covary age and gender from all the analyses, but I don't really feel like we could say very much about the men with only 12. But that's a really good thing that we definitely need to look at.
What would you guess you'd find?
Well, in terms of health, I would think that men, obviously their social networks, I think, are much more based around their, particularly in later life, I think, around their family, maybe not tending to have quite as many friends. I think, however, the friends that they do have, they share activities with. So I think that I think women would be more pulled off by, here's my actual prediction, women would be more pulled off by the family not feeling not comfortable with, whereas men may be more with the friends. What would you think?
Well, actually, I don't think men would be different. That's one place where I would expect them to be actually fairly similar, at least in later life, but I would think that the men wouldn't be very affected by being pulled off by their friends. So if they were pulled off all of you by family, I would think more. I would think women might be pulled off by both. But I'm totally wrong.
Good question. Melissa?
I'm wondering if you have any plans to have some cross-linkages between the two components that you presented separately today, and will we be looking at the network in the context of these traits?
Yes.
Repeat the question, please.
Oh, yes. So Melissa asked a good question about, okay, to what extent are traits perhaps playing into how these are the other things that you were talking about?
Your social relationships.
The social relationships.
Family, are people with certain traits more likely to have friend-focused or family-focused?
Yeah, yeah.
Does that play out in role too?
Yes, it plays out for sure, but I don't have those data with me right now. Yeah.
Well, we're right on time then.
Great.
Time for a break. We're going to convene here in 10 minutes.
Welcome back from your short break. It seems that maybe our break time was a little short. I'm loving the energy and the social networking that's taking place, and we would love to see that continue out into our reception and poster session after the symposium. But I have the true pleasure of introducing our next speaker, Dr. Alex Zautra, who is joining us today from Arizona State University, where he is the Foundation Professor of Clinical Psychology. And Alex directs a large and interdisciplinary group that studies resilience across the lifespan, among other duties and activities at ASU. And some of his most recent work is focused on social intelligence. And if that's not a familiar term, let me be the first to tell you that social intelligence, according to his website, not my ideas, too bad, is a framework for understanding and relating to one another that transforms us from isolated individuals to socially connected and aware people. In his most recent projects on social intelligence, he's using interesting, creative uses of games and gaming. And it turns out that relying on games is reminiscent of some of his early work a few years ago when he did his senior thesis at Antioch College. And while there, as I've heard, he also was engaged in some other interesting activities, including an unsuccessful run for Congress. And I've had the pleasure of knowing Alex and following this work for many years, and I'm so very pleased that he's here with us today to share his work. And please join me in welcoming Alex Zautra.
Thank you, Melissa. It's nice to start on an embarrassing note like that. But there were many more embarrassing things Melissa could have said. I'm happy that you left some of those items out that I gave you to say. You could have talked about. It's a pleasure to be here, and indeed, Indiana is such a beautiful state. It's a beautiful time of year to be here, too. And indeed, I did my senior honors thesis at Dayton State Hospital. I had a game called Monopoly, where I had people who we were hoping to get out of the hospital from their chronically ill, mentally ill state. And they played a game in which they went around the board collecting time, spending time at various locations. Some they could spend it either to try to get out of the hospital by picking the right activities, or to stay in longer, choosing the activities that get them in trouble. So we had a good time with that. But it's nice to be back in the spirit of developing means by which people can have a better life, and certainly to pick populations in need is of interest to us, our group. Resilience is sort of a main theme of a lot of my work, certainly over the last 12 years, or 15 years even. And social intelligence is the new arm of that work. It's informed by resilient work. The social intelligence aspect comes from actually I've studied social relations a lot throughout my life, but in particular coming to the conclusion that that resilience is social after all. And I have a chapter I just wrote on that, and be happy to share it with you if you send me an email, so you can get my rendering of that. So let's see. So how do I advance? Do I use the clicker? Yes? Oh, okay. Without the light. Ah, okay.
Speak a little louder for the people in the back of the room.
I'm sorry?
Speak a little louder for the people in the back of the room.
They've asked me to speak a little louder. I want to make sure I repeat everything that's said as well. So I'll try to speak a little louder. Can you hear me well now? Is that better? All right. So to map out what I'm going to be saying today, I'm going to start with a description of some of the findings from a study of resilience we've done on midlife, funded by the National Institutes on Aging. That study informed us about the critical nature of social relations in physical and mental health of people at midlife. Then I'm going to talk about two interventions that we've worked on. Both are online or could be online interventions, and with a modicum success for each of those interventions. I was not satisfied with the results of those interventions, though they had great promise, and my colleagues may still think they do, but I myself thought it's time to move on, and that's why I'm going to talk about a social intelligence intervention that we're building, and particularly valuable, perhaps, and relevant to the topics today. The idea is a social intelligence applied to people as they age, perhaps interrupting some of the poor trajectories in the lives of people middle life, to interrupt the possibility or the increased inevitability of health downturns, reducing that for those at risk. But also we're thinking of social intelligence applied to training of caregivers, professional caregivers, in particular in life care facilities. And you'll notice I have a colon to my talk here, which doesn't show up now. I have to go. Can this go back? Yeah. Which is humanization of social relations. So that's really what the social intelligence program is about. And with caregivers in life care facilities, it's about reacquainting with them and giving them a greater sense of how to humanize their relations, both with each other, as staff, but also in their staff-resident relationships. All right, so that's the overview. Now, resilience itself comes in many forms, and the processes that underlie resilience, you may come to mind several aspects. One way that people think about how to be resilient is to be meditative, to go on hikes, like this woman on the top of one of our favorite hills in Arizona, in Phoenix. Now here's another one. We published this handbook called Unlocking Resilience as a manifestation of the vitality of strengthening musculature. Okay, that's true. Our definition of resilience overall, in terms of outcomes, has three parts. Being able to recover quickly. You could think about this recovery psychologically or physiologically. Sustainability, which is you don't shut down, you keep going, so it's not interrupting goal progress, as in Karen's talk today. And then growth, or learning from experience. Successful adapting to change, to stressful events, but change is not done in isolation. It's not a lonesome task, but a social one. There's usually social ingredients to everyone's fulfillment of a goal. Social relations are involved in every time a person says that we're able to overcome a difficult time. Now, the media and the events that discuss the greater capacity of individuals to be resilient almost inevitably focuses on the qualities of the person. So I'd like to change that somewhat today to give you attention to the qualities of the social relations that befit us, that allow people to be resilient, and then to say to themselves, look what I've accomplished. The truth of the matter is, if they attribute it carefully, they'll see that other people are fundamental to that progress that they've made to make their lives, to be able to recover, sustain activity, and to grow and learn from life challenges. Here's a favorite paper of mine, and probably of some of you as well, certainly those of you in academic life who've studied the relationships between, well, here, social relations and mortality. This was a meta-analysis of 148 longitudinal studies on aging, over 308,000 participants, followed an average of 7.5 years, the average age of 64, and then followed after that. 50% increase in likelihood of survival when recontacted if they had strong social relationships. So social relationships are good for mental health for sure. They're also good for physical health in many ways, and the avenues by which those effects play is important to study. And of course, longevity is associated with strong social bonds. Okay. I wonder what that red line means on the top of mine. Well, nevertheless, you don't see it, so that's good. So, resilience at midlife is a community study that we've done here in Arizona, studying 800 people across 40 neighborhoods of metropolitan Phoenix. We picked 40 census tracts that were representative of 10 neighborhood types and selected 20 people, men and women, for each of those 40 to get 800 people. It's a 5-year study funded by the National Institute on Aging. And we were interested in studying those forces, both good and bad, within the person and their social worlds, to distinguish those who successfully adapt to adversity and those who don't. Here's a picture of Maricopa County. And I live, well, I guess there's another pointer here. I live downtown somewhere. We use self-report questionnaires about neighborhood social connections, child attachment and trauma, and personality. We did telephone interviews in which we got narrations of the people telling us about the most stressful time in their lives. They answered questions about their health and their state of mind. For a quarter of the sample, randomly selected, they received micro-longitudinal assessments, as well as home visits. Well, we did laboratory stressors on those same people, with 1/4 of the sample, with physiological and psychological responses to stresses, as well as home visits on the entire population, blood work, blood pressure, genetic analyses that profiles these people in terms of and also BMIs and other body mass index, and other indicators of the allostatic load or the relative physiological and psychological condition. Now, I'm going to focus on a couple of stressors today, but we did a large panel of assessment of both major life stresses in the past year, traumatic events throughout their lives, and some ratings of chronic stress, but including reaching into their retrospective accounts of childhood stress, childhood trauma, particularly through abusive relationships in the home. Now, how do we know if someone is doing well? These are the kinds of outcomes we picked. We had measures of psychological well-being, psychological distress, and physical functioning, functional health. This is a rendering of the confirmatory factor analysis that was done to distribute these scores, well-being, positive affect vitality, measuring psychological well-being, anxiety, depression, negative affect versus distress, and social and physical and emotional role functioning, pain functioning, or physical functioning. I'm going to talk about some of these measures as we go on through the study. Okay, one of the things I just did before coming here, because I want to make sure you get a sense of what some of the findings are. This study is just unwrapping. We finished data collection just recently, so now we don't have all the answers to the questions you might want to ask about what we have in the data set. But I wanted to give you some rendering. So this is a simple multiple regression analysis looking at key factors on poor physical functioning. And that's the physical functioning measure you just saw in the previous slide. These are some of the variables that show up and are continue to stay in the equation as we enter more variables in. Childhood adversity, in particular, emotional abuse, okay, in childhood. Sexual abuse and physical abuse are also in the equation here, but emotional abuse is one that occurs much more frequently in the sample, and also so about 20 to 25% of the sample reported some emotional abuse in childhood. And it was correlated with poor physical functioning. Life history of traumas, another that stayed in. These are mostly traumatic events of a social nature, okay? Financial downturns has surprisingly stayed in as a powerful indicator of physical functioning, and not just physical functioning. As it turned out, we conducted this survey right during and after the recession of 2007, 2008. It was on people's minds. It was had a powerful effect on the lives of these people. And you might think it affected the people with the lowest incomes, and we had a wide range of incomes in our sample because of how we selected our sample. But it affected mostly those of middle and upper middle incomes. I think they perhaps had the most to lose in the financial downturns. Negative family ties, also strong predictor of poor physical functioning. Now, when you graph this is another confirmatory factor analysis. You look at variables like emotional well-being, distress, and physical functioning, those three factors I mentioned earlier. The negative family ties affects all three. Positive family ties plays a role in regulating the degree of negative family ties, okay? And together relate to these physical functioning. You could say, but now I want to talk more in micro about the financial events briefly, okay? Because we often neglect to think about whether these economic events play a role in the lives of people, and if they do, how they do, okay? So this gives you an idea of the frequency of the reports, of the occurrence of certain major financial events taken from the Perry Life Event Schedule on the lives of our 800 residents. Oh, by the way, I didn't mention earlier, but maybe it was on the slide, the range of ages of the midlife years from 40 to 65. Relatively equal numbers of men and women in the sample. Okay. So as you can see, a major worsening of financial condition is the most frequently reported. People could report more than one of these events in a single interview, though. Pressure to pay bills by stores, creditors, or bill collectors, inability to pay for medication, medical necessities, falling behind payment and rent and mortgage. A lot of mortgage, people back in their mortgages. I know that's happened in Indiana, but in Arizona it happened in spades. 1 out of 10 people behind in their mortgages, and people going bankrupt because giving up their homes because of this. And our population, our sample, was among these people. Major financial events are correlated with psychological distress, emotional well-being, and physical functioning, all negatively and powerfully associated in this confirmatory factor analysis. Now, how do we know, well, how is it that these financial events have their effects? Okay. So one way to look at that is through these micro-longitudinal. So we looked into the daily diaries of people. We had financial events as one of the sets of everyday stressors that they could report. And people with more major financial calamities over the past year in their daily diaries reported many more financial stressors. So the question is, what is the path of distress for people with financial troubles? I'm going to get to that path in a minute. I want to mention one other important difference. There's another thing that those of you know, some of you know my work on affective complexity, is there's a fourth thing that happened to these people when we looked into their diaries of the relative change in the nature of their emotional experiences. That generally speaking, reports of positive and negative emotional experiences, positive and negative affects, they're not independent, but they're relatively different or significantly. So you can get, a person can be high on, they can have positive emotions, but they also can have some negative emotion too, or they can have none of either, okay? The important thing to know is that we're complex human beings emotionally. We have lots of states of feeling, sometimes depressed, sometimes tired and weary, sometimes delighted and excited, and sometimes we have all of those feelings. Well, the thing is, the affective complexity of our lives is one measure of psychological health, okay? The relative independence of positive and negative affective states. What we found is those people with strong financial burdens, okay, many major financial burdens in the past year, the size of their affective structure shrink. That's how we'd say it. There's a lot of ways of saying it, but anyway, the relative balance of affect was different, certainly more negative affects, fewer positive affects, but also when they had more negative affect, they also had less positive emotional experiences. There's a stronger inverse relationship between those two. So that's a fourth category of outcome that I added here. It's true for those with many financial stresses. Okay. Now, but digging into the diary data, what we found was interesting was that, and these are some of the everyday events, expense, overdrawn account, ran out of money, gambled it away, creditors calling. Where did this, how did this affect their well-being? Well, we found that the primary source of the difficulty that mediated, that played a role in how the person then became unhappy with their everyday lives, was through social relations, okay? That is, an increased negative social interactions with family and spouse and with friends. Actually, not with friends, but with spouse and family. And family in particular played a role in reducing the positive emotional states and increasing the negative affective states of these people. You could chart it like this. Negative financial events lead to negative interpersonal events, lead to more reports of interpersonal stress, and then to more negative affect. One after the other. So even with financial events which are not interpersonal or social, still it's a social problem, you see. It happens in the interior of the everyday lives of the families of people undergoing financial crises. I have that income variable in there too, just to remind myself to tell you that it's not a straightforward relationship. And again, it was not the poorest, although they struggled, and not the wealthiest, but it was those with incomes between $60,000 and $120,000 a year who were most affected. They reported the most disturbance in negative interpersonal relations as a consequence of the daily financial events that they had. Now, we also, in our interviews, daily interviews, we asked people to report on positive social experiences, okay? And although financial difficulties increased discord, they did not reduce positive social experiences, and in some cases increased it. And those with more positive social experience were less affected by that discord. So if you graphed it, sort of, it would look like this, where positive interpersonal events increased positive emotion, which then played a role. I'll have these arrows intersecting, you see. And that in the language of statistics means that these moderate or influence the relationships. So that means negative interpersonal events have increased interpersonal stress, but if the person has many positive affects, they have, if that is co-occurring at the same time as those negative interpersonal events, that relationship is weaker. And same with interpersonal stress and negative affect. That relationship is weaker for those who are able to garner positive emotion. You know, when you think about it, you know, Karen just talked about extroversion a little bit, and that's one personality source of people higher in positive emotion. But extroversion involves a strong social component, okay? And in some of my past work, I'm pretty interested in positive emotion, and people in positive psychology very much interested in the role of positive emotion in affecting, changing, accenting, increasing the capacity of people to be adaptive, right? That's vitality, energy, strengthening, okay? But when you ask yourself this question, which I've been asking myself lately, where do positive emotions come from? They are primarily sourced in social relationships, you know? Our most positive affects come from the comfort, care, or the excitement in our relationships with others. So that's why I'm focused on social relations, okay? Now, here I have a graph of some practical uses, and I'm going to focus on the, well, social intelligence training. But there are other courses, ways in which we can develop the means by which to help older adults in their everyday lives, including social cohesion, community gardening, just as one example, building neighborhoods with closer social ties, and that would help that. E-health with depression and chronic pain. I'm actually going to talk about that a little bit. Elder youth mentoring, I'm not going to talk about that, like in programs like Experience Corps, where we can get people who are older to play the roles that they're really potentially valuable in, and that is showing, displaying, using the wisdom that they've gained in their ages to inform and help younger people. We did this one intervention called the Baby Boomer Depression Automated Phone Interview Intervention. We had 3 conditions: mastery, control, mindfulness, and acceptance, and the health tips, which is like a public health intervention. We did this by telephone with our colleagues from University of Connecticut, automated telephone service. Course of treatment, 27 days, 21 daily diaries. We had 2 prior to treatment, and then we charted them in diaries. Now look, over time, we clustered the days into 11 different clusters here. Health tips is HT, MC, I think it was mastery and control, and MA is mindfulness and acceptance, okay? And what you see is a downward pull of depressive symptoms. We selected them to be depressed. No surprising, actually, that they then got better all by themselves to some extent. Now, there was some evidence that, well, there's no difference, really. There's some evidence, well, significantly, statistically significant, yes, both the control, mastery and control, and the mindfulness reduced depression more than the health tips did. If you look at the end of the graph there, at times 10 and 11. Positive affect across days. Okay, here, people getting these telephone calls from mindfulness and acceptance, and to a lesser extent, the mastery and control did better than those who just got health tips. And physical health, role physical health reported over time across the diaries. Indeed, the mindfulness accepted, they looked like they were doing stunningly well. Okay, one problem here. Our findings, our improvement in these conditions did not last. Okay, in other words, we didn't report this exactly in our findings in the published paper, which you can read, and I think it's in your documents here. But the truth of the matter is, they lasted only as long as the intervention did, and then a couple days longer. That was it. That's not good enough, you know. It's just not good enough. Well, I thought I got rid of this one. Doesn't matter. It doesn't matter. You can't read that. You probably can't read that in the back, can you? All right, you don't need to really. If you want to, though, you can ask me and I can send you the detail. This just gave all the sessions. There were 12 sessions. In this other condition this other program, we treated people with fibromyalgia pain. We had 29 people in the mindfulness condition and 40 people in the health tips. Same health tips as the other one. But this is about the same mindfulness condition, but it had a better focus on chronic pain and how you could help yourself, and which included 12 online sessions. Okay. And across days, indeed, the health tips, well, they didn't do so well on pain coping efficacy than the mindfulness condition. And on positive affect, the health tips, well, they actually started getting worse, okay, over time, that dropped. But the mindfulness condition, they seem to be getting better, all right? That's a sustainability of positive emotion across time. Enjoyment of family relations, you see this increase over time in mindfulness and self-acceptance intervention compared to health tips. Now, we think this is a valuable intervention, but again, the same problem, that it lasted as long as we were doing it. As long as the people were doing it, they seemed to get better. And it was better than the control group. And it's very important to have a control, no doubt about it. But nevertheless, this study just published in, I think, Annals of Behavioral Medicine. It's not listed in anything, but I'll send you the reference if you'd like. And we're very happy with the results, but I'm displeased with the results. They're not good enough. If we're going to build interventions that work, we need them to last. Now, it could be a part of the problem, could be the fact that, well, they're online interventions, right? They're not group-based, okay? They're not therapeutic, really. But I think the problem is they don't focus on the right thing, okay? I mean, if social relations are fundamental, then we need a program on social relations, okay? And so my wife actually got me into this, I'll tell you. Social intelligence training, we thought, ought to be the focus. I mean, being mindful about your relationships, sure, that's important. I mean, being able to step back from your everyday automaticity and behave in an authentic way by knowing what you feel. No doubt, that's important. But, heck, you need to know about social relations and why they're important too. People need the training in that. So that's this one. This picture is one, it's sort of taken from Gargazaniga's work, but we're not really just one mind. Our minds are always connected with others, automatically. We just are. I mean, that's sort of the social self is really the self, okay, fundamentally. And so, how am I doing on time, by the way? 20? Ah, okay, so you got some more time with me, I'm afraid. So here it is. Social intelligence is the awareness that life is best understood and lived in relationship with others. The problem is, I think it's a social problem throughout our society, is that we're become relatively indifferent, okay, to our social selves. Okay. At least we placed it lower in the hierarchy of need, okay, than it needs to be, and than it should be. This is our definition. Social intelligence means being able to, I have the word navigation in here, you see? Successfully navigating the world around you. I was going to tell a story about me getting lost in Rocky Point, Mexico, and to talk about navigation and how my wife pulled me out and said, why do you keep, this is a Mexican village that my wife and I visit all the time, once a month almost now. And it has some challenging geographic features, you know. My wife is really good at geography. I used to think I was masculine, big part of the brain where can navigate geographic regions, but she is better than me. She says, Alex, why do you keep asking me where to go? We're going down the street, do I turn left or right here? I'd say. And finally, this is talking about social support. This is the kind of social support that comes from conflict, you know. She said, look, figure it out yourself next time. I'm not going to tell you anymore. So indeed, I learned to navigate using a part of my brain I didn't think was there anymore, I guess. But successfully navigating the world around you socially is part of what social intelligence is. And this is the primary definition you'll find in the literature. It's fundamentally built on social competence, or learning the social skills, empathy, perspective taking, you know, learning to listen, not talk, not just talk anyway. All those things that you're supposed to have learned at home, you know, with mom mostly, okay, or in school, but you didn't, and now don't know at all. But this social you know, I talk to my students in clinical psychology. I say, right now you are very empathetic people. Okay? But the problem is, if you get into academia like I did, 30 years in, okay, you've totally forgotten about how to be empathetic because it's all about performance and research and quantitative methods. Okay? Thing is, my approach is now to say, hey, look, we need to return to our roots and say, yeah, these qualities of the person in relation to others are fundamentally valuable and purposeful, okay, and useful in navigating life, in meeting our goals. Most of our goals are social anyway, okay. Most of our burdens are certainly social too. We've taken it a step beyond the social competence, though, idea, because social competence and social skills, as you know, can be used for good or ill. And there are many examples of people over manipulating the world around them for their own purposes. Short-sighted, one would say, but certainly in the process, they certainly could say they're socially intelligent. I would say not, okay? And our view is because they're not taking the long view. In the long view, it's the strong social bonds, not the getting away with it, that makes a difference, okay? And that's what's that's what gives health and strengthening to the physiological systems that undergird our adaptations, is a strong social bond. So it's a shift. The second part, shift in the sense of self in relationship to others. So this is the humanization of social relations fundamentally, is it's not me but we. So it's again getting back to the idea that we belong together, you know, and not apart. That social intelligence training would be most valuable to teach. The skills are important, but they I pick them as secondary. Getting the right attitude and motivational state to say this is important, the skills will come naturally. The brain will learn. Once it has when it has the goal in mind, it will find a way to read another person's facial expression, okay? It will find a way. Except for those people who suffer from Asperger's or on the autism spectrum. Fundamentally, most people are quite capable of reading on other people's emotion. They have to remember to look. They have to attend. Okay. So, here's consequences of a lack of SI. This, many of you know already about: disconnection, disregard, disengagement. I could have presented a number of studies about loneliness, about the increasing lack of empathy in youth, or the increasing burden that comes from being bullied in high school or middle school, and how those effects continue throughout a person's adult life. But I want to just get to a more broader concept of what we're talking about here. We really come up with some principles that then guide the development of the interventions. And we have a prototype that we've built. I'd be happy to show it to you if any of you are interested. By going on our website, I can give you the password so you can actually see it. But it's fundamentally built on some principles. And the first principle is the one I've already mentioned, is humanization. And these others, I'm going to talk about in a minute as we go through them. So, humanization, we're not a collection of body parts. The people we look at are not a collection of body parts either, okay? And so it's important not to see people as a chess piece to be moved, okay? That's the manipulation standard, but that people are real. I mean, they're right here, they're right in front of us. And think about this in the development of caregiving strategies and training for professionals. Nurses, for example, who have often forgotten their roots in nursing, in their caregiving in life care facilities, is to see the other person for who they are, really, right there, not just the medications that they might need. Right? Our brains are built to experience what other people around us experience. So some of you are aware of the studies of how pain is, both physical pain and social pain are felt by the person watching the other person. Like you put two people in an fMRI and one person is given a painful stimulus and the other person is simply observing it on the screen. You can see the same portion of the brain almost light up. And the person is observing rather than the person seeing. Interestingly enough, this is also true of social pain. If you see, you can feel another person's loneliness. It's the feeling you have within you. It's happening in your cortex, of course, as you mimic and understand that, you know, you are connected to the emotions of the people around you, if you allow yourself to be. The study of Alzheimer's patients and their empathy shows that they actually have more emotional contagion. They're more connected to the feeling around them, okay, which is a problem that needs to be solved, okay, to some extent, by the way the caregiving is structured to help these people in their social relations. It's not true, however, that we're wired to connect to people who are different than we are. And we are a classifying, grouping, in-group, out-group species. We do this. And we do it some to our benefit, but we also do it that harms us and our social relationships. By grouping people in categories, black and white, Hispanic, Anglo, old, young, all these classifications often lead to stereotypes. If a person is in your out-group, you don't feel what they feel. If you see them in pain, you might have Schadenfreude, but you don't have a positive empathic response. Okay? So part of our training is based on the principle that each person is unique. Okay? And in order to understand them, we have to understand not as a group, okay, but as an individual. So see others as they see the world is the mantra that informs a set of sessions in our social intelligence prototype. Now, I just mentioned in-group and out-group, and that's really important. But it's also important to recognize that our brain does this automatically. And a lot of our functions, cognitive functions, are automatic. They're not based on awareness, okay? 95% or more of our neural processing is done without our awareness. So using work from Kahneman and others, it's important to recognize that we're built to categorize, we're built to segregate, we're built to expect and then to reconfirm our expectations about the world around us. Those expectations, they could be built from our early childhood experiences, our adult life experiences, our experiences in marriage and divorce. They color the way we see things, and in doing so, they're natural, adaptive processes, but they also lead us to be changing ourselves and the people around us if we're not careful. So understanding this means we should be more accepting that people often don't intend to mistreat us when they do, okay? And that we don't intend to mistreat or misjudge others when we do. But when we're aware of it, then it's time to do something about it. And about relationships, they're not automatic. the immediate gratification that comes from a good synergistic relationship connection. It might be, but certainly adapting an understanding, caring of the person as a whole, not just the halo effect of their wonderful person. It requires us to not only create a weak tie, but strengthen that tie, and doing things to maintain the relationship. And then finally, this is one we're building a new module on. It's just about choice, which gets back to the humanization principle that is applied to the individual who is getting the training, which is that we make choices every day, thousands of choices every day about whether or not to connect with another person, to relate to them as another human, or just to treat them as an object or someone to push aside. This is natural, okay? But we do make choices. And as humans, we're human as well as the other person. We make those choices, and the more we're aware of those choices, the more we're responsible for the choices and the outcomes that they bring. So choice is built in, sort of an existential principle, but it's built into the modules. In this case, we have 53, about average 5-minute sessions. Okay, 5 minutes because, well, attention span these days, 5 minutes is about it. But discussion can happen after that. But nevertheless, that's the way it's built. Built to be modified, of course, because we get started with one prototype, 53 sessions, 7 modules. We're building it out to have 8 modules, probably the same number of sessions. And it's made, we have different focus conditions, places where we like to put this one. Now, on this graph, you see soldiers. We're not sure we're going to do that. But juvenile detention center, we're planning, we have the go-ahead to build an intervention for, in their education programs for juvenile offenders. In middle school and high schools, we have a set of plans to build these for youth. And we've already piloted them in one school and beginning in others now. Now, the hand-holding, well, that may be not the best representation, but it's not bad. Caregiving is another. And there we have 2 projects in mind. One is to uplift the organizational climate, the feeling about the life care facilities in which residents find themselves in, by training the staff to be better, more socially intelligent with one another, and also in their interactions with residents. That is, to see them, to put meaning of the words of patient-centered care, okay? To give it real purpose sense than just lip service or hospitality, which is sometimes called. And then we're also planning a project on to encourage midlife, a sample of midlife people in our other sample, the resilience sample, who are potentially vulnerable because of childhood experiences, because of traumatic experiences, otherwise, or other evidence that they are vulnerable, that their midlife could be the trajectory toward difficulties physically and emotionally might be interrupted by better social intelligence training. Okay, so I think my time is up, and okay. So, and so just write us if you'd like to learn more. Be happy to talk to you. Thank you very much. Deborah, yes.
Thank you. This was a terrific talk, and I love the video of SI. And it sounds like this model intervention is targeted really to face-to-face relationships at a point in history when young people are doing more texting than talking, more Facebooking than face-to-face interaction. And so are there ideas or themes here that could be transported to virtual relationships, or did you view it really as specific to face-to-face?
That's a great question. The question has to be whether the concepts, ideas here are translatable into to deal with the problems with technology and virtual communications, and it's so popular among the youth and older adults. We're planning to, in fact, we almost got it worked out. We're going to have an app for a cell phone, okay, so that the program can be utilized while the kid is there waiting at the bus stop or whatever. And for older adults, certainly it's online now. So it could be used on laptops, that sort of thing. But, you know, some people talk, Daniel Goleman in particular, on his book on social intelligence, talks about the potential harm that new technology has caused. And I think we talked about this earlier. We think it's a plus and a minus. I mean, there are lots of potential benefits to social communication that come from Facebook and texting and other methods by which people can have instant communication with others. The question is when and how. Those of you who teach classes, you know the problems of people getting on their cell phones or otherwise not showing continued interest in what's going on right in front of them. People in conversations with family members. You can see a collection of family members around the table, dinner table, and they all have cell phones, and they're not talking to each other. So obviously some regulation is needed, but who's going to do the regulating, you know? There has to be more awareness of the nature of the value of not using cell phones and what they are good for, I guess. We have it in our program, actually, the cell phone thing. Yes, sir?
Somewhat related, we gain a lot of communication, a lot of information in face-to-face communication, and you know, this is not really my area, what you're talking about, this social interaction and so forth. But it seems like we may be, part of that loss you're talking about is we may be losing the ability of effective communication without the thing. If you don't have the device, your communication is not as good. I mean, making it even worse. There are things like, I used to do a fair amount of reviewing of grants, and you go in and have these meetings and discuss grants. I've been doing a little of that, and I've decided I don't really want to do it because I've been in sessions where it was clear we had 3 days in a row. We all read this bigger project and all read it. We're supposed to block out our time. And first day, you know, we talked. The second day, it became very apparent that one of the individuals totally misunderstood what we were talking about in one factor, which I think in a face-to-face conversation, we would have picked up those non-verbal cues to go on. So if you've got any comments on that sort of thing, I think
the gentleman tells us about the nature of the experience as being not allowing all the channels of communication to come through. Body gestures, tone of voice, facial expression, all these things are missing from, online communications, you know. We were talking about this today. In fact, actually in my class we were talking about this, a new way people, they use emoticons, you know, little faces to try to express their emotions. But that's really pretty remedial, you know. But my guess is technology will catch up to that game someday, allow even more awareness of the whole person in their communication, and likely possible. But you're absolutely right. There are limitations to what the current online communications can give us. And face-to-face communication is more satisfying if it's a good connection, right?
Yeah, I was really wondering, though, you said you had actually said there were pluses and minuses to the technology, and I was wondering if there were some other minuses and pluses you might address. Now, obviously, one plus is the ability to easily communicate with people, relatives, friends that aren't there, you know, different city, different place, in the same city, wherever they are, and you need to talk to them, especially someone that you want to talk to, and you can't quite go visit them. I know there are a lot of little changes to this, but you might comment on that.
The gentleman asked me to comment more on the pluses and the minuses, but the pluses with regard to technology in regard to building social relations. I'll give you a personal example, which might help, is that, and this is something my wife tells me I'm not to do ever again, which is, she's right about this, which is to talk on my phone while I'm driving, okay? So I have a sister who lives in New York City, and she's very dear to me, and so I'm talking on my telephone, and I'm about to make a left-hand turn, and I do, this busy city street in Phoenix, and I swear, I was not at fault, but this car came crashing through and smashed right into me, right? But here I had my sister right there. She was right there, where I could say, look, I'm okay, I've just got it, and she could hear the cracking, the metal coming. The car was totaled, which actually was a good thing, I tell you, because my wife and I had gone to the auto dealership just a month before and bought this brand new Hyundai, but she thought I wanted this black sporty car with the red seats. And I thought, knowing her, that she wanted the black car with the sporty seats. So we bought the black car with the sporty seats. Neither of us wanted this car. Talk about communication. Face to face, right there with a salesman. So we now have a Hyundai Sonata. But nevertheless, there are times, even, it's not always like, the reason I bring this example up is it's usually to think about technology, social media is good for surface communication, which is many more people potentially in your network. But it's also true potentially valuable in other times, in times when you really need someone to be right there with you. And sometimes the voice, and you can feel emotion through voice. That carrying is right there. So there you have it, an example. I think we probably exhausted this time. Thank you.
It's been a great day, and I appreciate our speakers. Would you join me in thanking Debbie Carr, Karen Hooker, and Alex Zautra? Sometimes I think that we feel we're not very powerful, but when you hear presentations like we heard today, you realize the power of social influence. So whether it's planning what car you buy or planning a living will, it's amazing the influence we have on one another. Before we head to our reception, it is our custom that we make an award at each one of our symposia. And this year, the award is being given for research excellence. One of our co-winners is actually a faculty associate of the Center on Aging in the Life course, and the other is a recent graduate. The committee considered a number of nominations this year and decided that they wanted to select co-winners, but these co-winners are attached to one another in one way. It is my pleasure to confer the Research Excellence Award on Drs. Jill Suter and Megan Gilligan. Jill Suter came to us in 2004 from Louisiana State University, and in her research career, she's received over $4 million in extramural research grants. She's the author of about 70 journal articles, referee journal articles, and about 30 or 40 chapters, and 30 of those referee journal articles have been published since she's been at Purdue. So she's been a very, very busy person and a very productive person. So when you think of many of these tricky relationships in the intergenerational context of a family, things like a favorite child or ambivalence or how do families talk to nursing home staff, people think of Jill Suter. Megan Gilligan came to Purdue in 2006 and recently earned her PhD, the dual title in sociology and gerontology, and she's now an assistant professor at Iowa State University. She's the author of 9 referee journal articles. Yes, that is correct. She's the author of 9 referee journal articles, and she just left Purdue in August. Each of these women has a distinguished record of accomplishment given their rank. What's truly special, however, is their collaboration. Jill has mentored Megan extremely well, and Megan has seized those opportunities. Together, they have an extraordinary record of scholarly productivity. It seems to me like they have a column in 3 journals: the Gerontologist, Journal of Marriage and the Family, and Journal of Gerontology Social Sciences. Beyond that production, they're answering questions that make a difference in family life. And for that, we congratulate you. Thank you.
First, thank you so much. I really feel honored by this, and I especially feel honored sharing it with Megan. And as anyone who knows me well knows, I've said to probably each of you, I feel like in my collaboration with Megan, I have always been the lucky one in this, that I think that this is a relationship where I've benefited much more than Megan, and it's been hard to think of myself as a mentor because Megan has been a collaborator for at least the last 5 years, and as someone whose advice I seek first on academic issues. So I feel I've been very, very lucky.
Well, I'm really grateful to be here today, and I was glad to make the trip back from Iowa to come and share time with Kelk friends and family. And I can't say enough about how grateful I am to have my collaboration with Jill. It's been a great 7 years, and I'm looking forward to many more together.
Yes,
it's a very exciting and really interesting collaboration.
Yes. Thank you. Thank you so much.
And on that happy note, congratulations to both of you. We will close this part of our formal talks and invite you to join us for a reception and poster session. And the posters are being presented today by student researchers, so I encourage you to talk with them about their interests in aging research, but also a little bit of housekeeping. To remember to fill out the evaluation forms that you were provided. The symposium is very much a dynamic living experience, and we want to improve it and make it as valuable as we can to those who are coming to participate. And let me close by just thanking all of you for spending the afternoon. And again, let's thank our speakers for their resilience in a long night and long day of talks. Thank you much.